So I'll just summarize the pattern of this conference and start to everybody. So we'll have theory question paper, which has 50 questions, and you have to finish within 1 hour's time. The straight answers are there in that. In that question paper, you have to write. You don't have to write your name. So team A, on your badge written A, B, C. So team A will be like what way we have written, B and C. So you become your teams now. You have to work together. All three teams have to work together. Right? So we give you a case scenario. You have to write in, will be given a copy also. You have to make the whole case of, long case of that case scenario. Here, you have to write the history, examination points, like it's a long case. Examination points, systemic local examination, differential diagnosis, investigation, provisional diagnosis, and final diagnosis, stage the disease, and write your treatment protocol and you have to sign. So one case scenario to one team. In all 11 of you have to sit down, concentrate on that case scenario because any question can be asked to any of these 11 members. From history to the recent advances. So it's a teamwork. Right? Got it? Now, that copy of what you have written is placed in long case and your copy will be assessed by the HOD and marks. The whole team will get the marks out of it. So please write the long case properly. It's a really long case and do it properly. And then on that case scenario, there will be a 110 minutes question and session, answer session will be there. This is about long case. Another part of the exam will be, will give short cases also. Radiology imaging will be asked, specimen, instruments and surgical steps. That slides will show you and the faculty and HODs will ask you questions, they will assess you. They will certainly reply if you have not given a complete answer and give you marks for that. So it will like the long case will be first year will sit here and third year will sit there. The sequencing that given 1.1, 1.2, 1.3 will sit in an ascending order, all these chairs from first to third. Right? So we will have 7 minutes of present history and summary and Q&A session, then systemic examination Q&A session, then local regional examination Q&A session, then word of wisdom by HODs. Then discussion on differential diagnosis, how to investigate the case Q&A session, final diagnosis and discussion on the final diagnosis and Q&A session. So we have given minutes to everything. Rehabilitation and treatment protocol, and then surgical planning, surgical steps will be asked, and post-operative management, and follow-up plan and advices to the patient, and the last 11 guide recent advices about that particular, whatever the faculty and HOD is going to ask you. So team A and B will go now for 1 hour time. Will start now for theory paper. You can take theory paper from Manisha ji and go down that side. Team A will sit on that side. Down. And team B will sit on another side and do only 1 hour time is there. So 8:30 till 9:30. 9:30 copies will be taken care of and for marking. Team C will give you a long case for which will be only 45 minutes. You have to write that long case. There will be a scenario here. So your scenario is for team C is this scenario. Take a copy. 11 guys or whoever team C group has come, sit down here and make your scenario. So we are giving you exactly at 8:40. We will take copies back from you within 45 minutes. I think everything is clear. Anybody any queries?
About the prognosis, what is the planning, what is the requirement of the adjuvant therapy, what is the further treatment we will plan, and then after every consent and after every understanding of this case, if patient is the non-metastatic and definitely operable, we will try to put this case for the surgical intervention.
Request to everybody, whenever you see a patient and you think it might be operable, right in the first visit, give him a 3-month inside the spinal cord. Right? Ultimately, he might come, he might not come for surgery. But start the chest physiotherapy right from there. Right?
So, what will be the first step in
when you encounter this patient, you have admitted this patient into the ward, then you said that you will do PAC in other things. What will be the first? For a patient is having jaundice. First will be resuscitation. Assessment is okay, you will send all those investigations, but you will start some hydration.
These are the key habilitation of this patient.
Rehabilitation that will range from like admission to the surgery. So that is a long process. But first, so what is the basic thing? That is the first. So suppose this patient is having jaundice of like 23. So what will you do? The patient with the total weight will be 23 and the colonoscopy performance is good without any symptoms of polydiabetes or anything, and patient is absolutely operable, then we will plan this patient for the exercise. There is some couple of days study 20, some says 25 for the pre-operative biliary drainage. If patient is unfit for April surgery or the not tolerable for the any type of intervention, oncological intervention.
You suggest how you can get some tissue diagnosis in this patient, methods of tissue diagnosis. Do we have to get a diagnosis, tissue diagnosis, and if so, how?
In this case, we can do a ERCP and biopsy. If it is not visible, then we can EUS guided FLC. If there is any lymph node, then can be accessible. We can access this lymph via EUS guided FLC biopsy. So is it necessary to get tissue diagnosis or? Sir, if we are suspecting the malignancy, then and patient is definitely operable. We will not do routinely to a biopsy, but if patient is locally advanced disease or the metastatic disease, we plan for neoadjuvant chemotherapy. And either we will go for the palliative unit, then we will require a tissue diagnosis for the circulation.
Tissue diagnosis has been very good. Now, how will you proceed with the consent? What will you explain to the patient and patient relatives? What can be the complications? How will you start with the consent?
Starting with the consent, we will explain for disease surgery is the major surgery. It will take longer duration of surgery, around 5 to 6 hours. Then we will explain about the in-round complication of this patient. Then maybe a blood loss. In-round injury of blood loss like injury to portal vein, major vessels. Second, if there is patient has a risk of routinely has a risk of general anesthesia, then it will be a cardiac or respiratory events. Post-operative events, we will explain the patient about the anastomoses leak in the. First, we will explain about the patient of the long ICU stay if may require this patient. Second, we will explain the late post-operative complication like the anastomosis leak of pediatric digital anastomosis, pediatric digital anastomosis leak, for which patient may require a longer duration of the stay or the longer duration of hospital stay. Post-operative, there will be some infectious chances, wound infection, sepsis will be there, so we will explain all these routine. There will be a minor risk of immediate pulmonary embolism in these.
Re-exploration also.
And there is risk of also we will explain this patient about inoperability of disease if we find any metastatic disease.
What was mentioned by the authority sitting here about this part of the presentation? Dinesh? Comments? Suggestions, rather. What is in there? Dinesh? Amar?
just be careful while making the list of participants. Okay, as correctly said, the maximum amount of information is supposed stating something that will be the personal failure to the adult pancreas definitely will come first in the list. You won't talk of asking a more better here because you have already committed that itself from globular regular margin model. Be careful while making these lists. And regarding the investigations, I think in any abdominal case, I think it's better to start with the ultrasound and go forward. Anyhow, we are going to do CT or MRI CT here in this case, but a lot of information can be still considered part of the information. There is no harm of getting that. And suppose if there is a specificity of any AAG here, or even if it's not there, and we are suspecting strongly career immunity, but can this be also important? To have a scientific institution is to see at least the criteria.
Use AI, whether it is DeepSeek, Meta, AI, ChatGPT, or anything. Ask what are the possible Viva questions in a case of jaundice. वो सारा बता देगा, उसका आंसर समझ गए?
What is iris node? Straight answers. Iris node. What is iris node? Left axillary. So, in what cases you get these nodes? Say so. Good name. Jenny is going to speak about the surgical plan and what surgery, the detailed surgical steps in this case.
Right? So, 2 inches.
You want to do surgery or not in this case first?
We investigate the patient.
What is that? What is the diagnosis? Very important. Right? You want to do surgery, you don't want to do surgery.
We'll operate the patient.
You want to do surgery. So tell me, please. What surgery? How do you prepare the patient consent and everything that way?
We get a pre-anesthetic workup done of the patient. Pre-anesthetic workup done for the patient. With the necessary investigation which were required after rehabilitation, and taking a proper consent and explaining them about complications and post-op ICU exploration, we will take out the patient for surgery.
Jenny, how much time you take for this case in your center for the consent? Presently. Minutes. Please continue. What can you say?
The consent is not that final day when you get the signature. The consent is a progression over a period of time with several multiple encounters. We keep feeding them with little information about the nature of the work. And finally, when you affix the signature, you may spend only 5 minutes. That's the difference because you're just summarizing the whole lot of information that you convey to them over several visits before.
So what exactly you tell?
Whatever Dr. Nathan says, that you take a 5-page, 6-page consent and tell the patient from right from A to Z to mortality, don't do it on the first consultation. Right? First consultation, otherwise now all your patients will right? Like Dr. Nathan said, gradually over the days, years, right? But consent to introduce what is the most important. It has to be a written consent. Some people now say it has to be documented with the readers, right? Because nothing happens. Once in a lifetime, one patient dies and he sues you, you can't.
Continue your surgical plan.
Take out the patient for surgery. The patient will be put under general anesthesia.
So what procedure you are planning in this case?
In this case, we do a staging laparoscopy followed by intubation of the into a business procedure.
Would you like to put a technical cut for the general?
See, when you talk about taking the surgery and the surgery plan, you have to do all the things. Position, hold placement, you can do the laparoscopy, you do the laparoscopy first, assessment first for all, position of the patient, position of the anesthetist, position of the legs, position of the hands, all that has to be mentioned in a very quick manner. And epidural, arterial, whatever the anesthetist want to do, right? And the blood reverse, and the blood, right lateral, left lateral, everything. Quickly ask that. So that the examiner knows, yes, you are doing it day in and day out. But
Patient is placed in a supine position.
So you have three systems. You have a laparoscope 4K, you have a robo, and you have a open. You are expert in all three: robo, open, and laparoscopy. You are expert in all three. What do you want to choose for this case?
It was minimally invasive procedure like the vertical laparoscopy. The expertise is available.
robotic, yeah, we have robotic. So right in the beginning, you want to put in your composer and all that, and then say, those are written in operator.
We put a scope and examine the patient first.
So what kind of procedure did you do this?
Staging laparoscopy.
Staging laparoscopy done.
Then following which visits, we planning if the patient is operative, we plan for this procedure.
So what are the criteria of operability in this case? When you can say it is operable, and when you can say it's resectable, there are two things.
Resectable is with respect to the tumor, and operability is seeing the patient condition. Operability is for the patient basically, and resectability is according to tumor, if it is abutting or adhering to the underlying vessels.
So it is the contraindication for surgery to be.
So borderline, there are borderline resectable tumors.
So define all three: resectable, unresectable, borderline resectable.
It is with respect to the superior mesenteric artery, common hepatic artery, or superior mesenteric vein.
Contemplate.
And the encasement regarding the same. If it is abutting and less than 180 degree, would be resectable of SMA. And borderline would be more than 180 degree.
Anybody can help.
SME
Take the mic and speak, please. Take the mic. Criteria, as six criteria.
For resectable, there will be some venous criteria. SME total length less than 180 degree of abutment of contact. In artery cases, no contact with vessels. In borderline, there will be SMB total length axis more than 180 degree of abutment, which can be resection and reconstruction can be done. In case of arteries, there will be less than 180 degree of contact. In unresectable, there is more than 180 degree of contact SMA total weight, which cannot be reconstructed or it is hummus, and along with more than 180 degree contact of arteries for unresectable. And resectability is an anatomical, biological, and conditional. First, we have to see the conditional, then biological, then anatomical. Based on these three, we have to decide whether the patient is resectable,
Operable. The mixing two.
Yes, sir.
Is operable. Disease-wise, resectable, otherwise operable.
Yes, yes.
Continue your weapon surgery.
what kind of anastomosis you will do?
So just there would be gastrojejunostomy, pancreaticojejunostomy, and hepaticojejunostomy would be done for the patients.
There are various types of pancreatic jejunostomy because that is the critical. So our focus will be on that only. Because other anastomosis are not difficult. So which type of PJ?
So depending upon the dilated, the diameter of the pancreatic duct and the nature of the pancreas, we can decide. We could Heidelberg technique could be done or
Because modified Gulbar.
Bloomberg.
So suppose like there are two small ducts, 2 mm each. So then
We could do the
1 centimeter away from each other. So two small ducts are there, pancreas is also soft. Then
we could do a ducting method where the whole of the pancreas would be anastomosis with the judgment.
While we were doing discussion about the local thing, we talked only about teeth. We didn't mention anything about pen. Which node, if you think, is involved in the understanding? So that has to be mentioned. Remember. Right?
Which area is the node and which number it is given for CAGB? Which number it is given? 16. 16 feet. Possibility management.
Joseph.
Louder.
Post-operatively, we will on the post-operative first day, we will select the drain fluid CA, the drain fluid amylate, and we will start the feeding judge loss fluid, which we would have done. So we will start the feeding on post-operative day 1, and then we'll, depending on the levels, we'll again send the drain fluid amylase on post-operative day 3. And while in the meantime, we will gradually increase the feeding from the feeding judge loss to be reduced, and from the post-operative day 2, we will mobilize the patient, and we will also start the spirometry, and we will advise the patient on physiotherapy and enoxaparin for prophylaxis of deep thrombosis.
Not even told anything about the pain management, not spoken about antibiotic treatment protocol. So classify your answer. Investigation part, treatment part, pain, nutrition, antibiotics. Follow it.
It's a broad spectrum antibiotic and coverage for anaerobe and anaerobe like non-negative, so we can start ceftriaxone, metronidazole, or aminoacid. And for the pain management, as we have already put epidural catheter, so we can the patient will be given propionate at a dose of 4 to 5 ml per hour.
Patient started bleeding on second day.
So patient started having bleeding second day. Retained as a blood. How will you investigate this case? How will you treat this case? And what are the causes of bleeding in this case? First etiology, then diagnosis and management.
In that brain, there is blood. So,
Second, third day.
so first we will get the blood picture of the patient, and accordingly, on the course of the 2 or 3, there is usually a gastroduodenal artery throughout. We can just that, and we can confirm it radiologically, and we can take the patient for exploration and navigation.
Deepak, you want to add something in this? Localized delusion. Then you localize what you can do. You want to explore, you want to do something else. Simultaneously, you are doing self-triathlon also. It does cause some sort of bleeding paralysis to these patients. Very rare phenomenon to open. But it may be the cause of, along with low platelets or it causes bleeding in these cases. That also should be.
Regulation also depend upon stump of bleeding we have left side. If it is available stump with more than 1 centimeter, they can go for regulation.
So what is your suggestion? If you are doing a web pulse, you want to leave a longer stump or you want to do a flush ligation on this?
Fresh ligation should not be done, sir. Yes, fresh ligation of GDA stump should not be done, sir. Especially 1 to 1.5 centimeters stump should be there.
How will you deal with
So while dissection, sir. So for while dissection, we have to first, sir, locate the complementary node. We have to go for complementary node dissection. Then go retrograde to
you isolate?
yes, sir.
Then what will you do?
So first we have to clamp the GDA, sir, and then again check for pulsation of hepatic arteries. If pulsation is there, then we are sure that we can safely clamp divide GDA stumps.
And my question.
Yes, sir. Double securing the GDA stumps, sir.
Suppose you are seeing this patient on post of day 5. So what are the things you can expect or some complications or so how will you do at the patient?
Waiting on post-operative time.
So any complications, anything might happen. So what are the things you will look for? You will have in your mind that these are the things so which patient might have.
So first, we can check for any food complications, any suspicious output in the drains,
Yes, one is the surgical site infection.
any suspicious bile leak in the drain which we have checked.
So commoner.
Then in
So how will you find out those that there might be easily?
we have already drain fluid amylase levels we have already set. So more than 3 times the normal value is suggestive of biochemical.
You should say you said blood also simultaneously along with the
So if it is more than 3 times, then what will you do?
It will be a biochemical leak that we can start the patient on octreotide. We can simvastatin analogs to lower down the secretion, and then we can keep the follow-up and rate that if the drain output is decreasing.
So then also we have to see the other things, whether patient is stable or patient is not stable, patient is okay, abdomen is okay, patient is not having any kind of symptoms, feeding is going very well. So other things are okay, just there is more than 3 times. Then there might be that you don't need to do anything because many times we see it is more than 3 times or 5 times or 10 times also. Then you have to see the amount of
volume.
Volume is set 20 ml or 10 ml. Then you might have, but that volume we have to see. If volume is large, and then with that, if that amylase is increased, and you have to see other things also.
clinical parameters of the
Clinical
patient.
parameters also.
Sepsis is there or not, volume of the fluid is how much it is, and it is 1, 2 or 3, which leak of PJ along with CJ or AJ, what is the leak size. All these parameters will decide your further plan of treatment in these cases. Because what is the follow-up? You have operated this case with quite well, no complications, third day discharge, fourth day discharge. What is the follow-up plan and advices for this patient?
We have to collect the final histopathology. We have to collect the final histopathology reports. Based on that, we are giving advice patient for the adjuvant chemotherapy, which will be gemcitabine-based chemotherapy. After taking consultation of medical oncology, we will follow the patient for initial 2 years for 3 to 6 months with tumor marker, the CA19S9, CA along with imaging. Then after
Which imaging you are talking about being very specific? When you want to use imaging and which imaging? If everything goes smooth, no complication, patients follow up 1 year. Then you want to do first imaging and then follow up with imaging. What are the investigations? For the
imaging will be CECT program plus predictor.
in all the cases, how much duration after surgery?
Yearly, yearly.
First imaging when?
First imaging after 6 months.
Nobody talking about bed strength.
perioperative with adequate imaging without any signs and symptoms of metastasis. There is no any role of PET scan.
Sir, there is a role of PET scan. Patient will come and say, PET scan, tomorrow I'm 6 months now. Can you refuse it? I'll ask my teachers to and the HODs to answer this question. Patient comes on 6 months of follow and says, आपने PET scan नहीं कराया. Why didn't you get a PET scan done for recurrence?
In this era of litigation, you should never refuse whatever the patient
This is the point, sir.
Patients desire the PET scan.
Luckily, I take that. But he is seeing no indication of PET scan, that's why he said that.
Typically, there are no indications if the patient asks for that, then we can.
Trust me, in your private practice, when you start practicing as a consultant,
Yes, sir.
litigation takes precedence over your clinical
Yes, sir.
How you subtract that patient difference or routine examination?
Routine. But sir, all clinical symptoms may be having respiratory distress, any abdominal distension, any abdominal pain. No, sir. Rest will completely, sir. Abdominal pain, abdominal distension, those will be complaint of nature. So this will be there, sir.
So the commonest pattern of recurrence after visits.
Low,
This is the question.
low regional recurrence, sir.
Very local region. Very local region, the commonest.
Retrograde first, sir.
Third dimensional clear. What is the symptom of that first? It is pain.
Pain.
Back pain relating to the back.
Which is usually positive margin in
Okay.
Why do you have to follow this?
Sir,
Why do you have to follow them? Just leave them alone. Scans.
sir, in pregnancy, that
What is the purpose? See, in oncology, every follow-up and every test has a significance.
yes, sir. Yes, sir.
Here we are dealing with a periambulary cancer.
Yes,
You
sir.
have resected it. They are fine. Patient is fine. You discharge the patient. Why follow them up?
So there will be there will be some micrometastasis will be there.
Doesn't matter. So the question here is, in follow-up, you did pick up the recurrence, which is what you are doing.
Yes, sir.
Follow-up. What are the salvageable recurrences in pancreatic cancer or periambulary cancer that you are going to deal with?
So can we say the first reason of following is legal? And then urgent process because it happens. Because the patient will come and say, आप मुझे पहले 6 महीने करना है मुझे आप मुझे पहले करा देंगे investigation
Social reasons are different.
Yes, sir.
The legal reasons are different. Social reasons are different. Patient is anxious, I want to have a scan, fine. Or you are in a very litigious climate and you want to protect yourself, fine.
Yes, sir.
But I am asking about science question. The science question here is, if you had a recurrence, what are the salvageable treatments you can offer in a pancreatic case, which you want to follow up with so many scans?
Most common recurrence is retrograde.
Earlier, we used to get stumbled with this, but now you cannot get stumbled because now we have modern genetic approaches for any type of cancers. Alright, so therefore, still you have an option. Either you could get some target from the tumor side, which is maybe having a drug, the druggable target, or you may in fact put them on a clinical trial. So if there was one suitable for that. So you cannot get stumbled by saying, I won't do this because of such and such reason. Those are the days gone.
And if you are very well versed with genetics and other syndromes and everything, then you can add, sir, he has a pancreatic malignancy. You might have some relation to other
Yes,
malignancies.
sir. We can.
So you will do that. Very last,
Genetic counseling.
which are the malignancies, which are the syndromes.
I am going to ask you, this lady on recurrence had a BRCA1 positive. What do you think?
Sir, she is a unique case of family. Other
Tumor, when you analyze the tumor for genetic study,
yes, sir.
there was a BRCA1 positive in this pancreatic tumor.
So screening of other organs should be advised for the patient based on the ARCA will positive. For that test,
So there are two things. There is one tumor ARCA positive.
yes, sir.
And there is the germline ARCA. I did not say it's germline. What is germline?
Germline, sir, hereditary, sir.
So how do you test? How do you test the germline? Blood. What component of blood? What is it? So blood will be protein. ARCA1 is protein.
Circuiting. Circuiting.
Circulating is what you do in blood. So you take what are the cells which contain nuclei in the blood? The lymphocytes. So these are all peripheral lymphocytes which contain nuclei. So if someone is hereditary ARCA1, this nuclei will contain the mutagenous ARCA1. That is how they identify hereditary germline ARCA. But in this case, I did not say so. You did the tumor whole genome sequencing. You found there was a ARCA1 positive. How do you handle this?
So we can actually
Very fine.
so we can do an HIV testing
Principle.
if the patient is HIV positive, we can act for pathfinders.
Yes. So now we end this now case number. Thank you very much. You guys did a good job. The first lecture for today's English class for you guys. Excellent. Muskara bhai. Listen to this. So today's first, you can sit there now, please. We have a lecture. How to write a theory paper? क्या simple सा topic लेके बैठे हाँ theory paper. Everybody knows what to write, how to write. The key to answering exam question, basic rules. Read the question paper. How many times people have thought, अरे ये तो मैंने पढ़ा ही नहीं. Check the command words. Section A, section B. These many numbers are compulsory. This is not compulsory. Options 3 out of 4. All those keywords you have to remember. Reread the question. Right? Somebody asks, what is periampulary, and you start away with pancreatic cancer or something else. Right? Write your answers and then quickly check what you answered. Again, read the question and write. And write according to the weightage of the question. You know something very well, but it is a short note, and you spent 5 hours on that short note. And so, check the weightage right in the beginning. How much marks for each section, how much marks for each question. So, check the weightage. First of all, the moment you go there, identify yourself. रोल नंबर लिखना बहुत जरूरी है. Don't think कि बाद में लिख देंगे. आराम से रोल नंबर लिखो. Take a deep breath. Inform your chief. You know who is the chief? Inform your chief. ठीक है ना? Look around and smile. दूसरों को भी smile करवाओ. ठीक है? It gives you confidence yourself. These are. Stabilize your table chair. ये हिलता रहता है कई बार एग्जाम में. Small little things will irritate you. So stabilize your wing नीचे है तो कुछ उस पे नीचे लगा लो. Your stabilize your chair. Organize your weapons. What are your weapons? Your pen, scale, ruler. Be very careful. Your boyfriend is giving you a pen के एग्जाम में यूज करना. मैं रात भर भगवान के पास में रखा है. वो मत यूज करना. पेन वही यूज करना जो तुम पुराना अपना यूज कर रहे हो कंफर्टेबल विद. ठीक है? Check answer books for any paper defects. There might be paper folded, there might be less number of papers, whatever it is. So always check your answer sheet. First, write your roll numbers on any section or supplementary or whatever it is. Take deep breaths. Paper आने में भी time है. वो घंटे बजेगी, उसके बाद में paper release होएगा. तब तक ये सारी चीज कर दो. And then remember the examiner's psychology. वो बैठे हैं देखें उधर डॉक्टर बोला वो एग्जाम की पेपर चेक करते हैं. ठीक है? इधर एक्टिविटी चल रही है, सब कुछ चल रही है. He just has 5 minutes. डॉक्टर नितिन पीछे पड़े हुए सब जल्दी चेक कर दो. He just has 5 minutes. है ना? पेपर चेक करना. What does he want on your papers? He wants a crystal clear thing. He wants to know what type of a personality you are. Your personality gets reflected in your paper. तुमने सारा घिचा पचा कर रखा है, तो शुरू में ही सारा impression पेपर हो जाएगा, right? So see what the examiner, he just gets minimum time, and that is the game that you are playing. In those few moments, you are writing your life. समझ गए? So prepare for it very well. Understand the pattern of examination. What type is it? Objective, short notes, long answers. What are the parts? Section A, B, sub A, 1B. How many marks for each section? What is the time allotted? And what are the topics that you have to cover? Read the question paper carefully. Most do mistakes here. Write the question number in part A, B, C very clearly on the left side. Write preferably 1 to 5 in order. Write legibly. Highlight the important points with color pens. You can use color pens, but not red highlighter. Write in points and bullets. Nobody wants to read big paragraphs. Yes, if you don't know the answer. Supposing the question is, describe the anatomy of the inguinal canal. छोड़ो मत question को, लिख दो कुछ भी. The inguinal canal, this thing is situated where the body meets the lower limb. It transmits the major vessels, it transmits the nerves. कुछ भी लिखो, लिख जरूर. खाली नहीं छोड़ना, नहीं तो जीरो मिलेगा. कुछ भी लिख दोगे, थोड़ा तो इतना तो पता है कहाँ पे होता है inguinal canal, तो उसका कुछ नंबर मिल जाएगा. Use flow charts, tables, diagrams. मेरे को अगर कोई एग्जामिनर तो पेपर आता है, उसमें खाली फ्लो चार्ट्स, डायग्राम्स होते हैं, मैं फुल नंबर देता हूँ. पूरा पढ़ने का मेरे पास टाइम. आई हैव नो दिस थिंग कि मैं पूरी उसको पढ़ूंगा, एक लाइन को जो तुमने सेंटेंस बना रखे हैं कोई नहीं पढ़ेगा. फ्लो चार्ट्स, डायग्राम्स एंड टाइम ईच क्वेश्चन. यू लाइक योर स्वीट्स, ठीक है, डेजर्ट पहले खा लो, लेकिन बाद के लिए भी टाइम तो है, राइट? And remember, filling more pages does not mean more marks. तो वो तुम अपने बगल वालों को प्रेस कर लोगे, इसने 3 सप्लीमेंट्री ले ली, वो मेरे को भी लिख लो. वो बड़े लिख के पेपर छोड़ के, no, it doesn't make a difference. Don't do the following exams. Do not jumble the questions or parts. कि section A यहाँ कर दिया, 1A and then B कहीं और, वो examiner ढूंढने में उसका मूड खराब हो जाएगा, तुम्हारे नंबर कट जाएगा. Do not highlight in red color. Do not write in long paragraphs, long stories. Do not waste time writing one question for too long. बहुत अच्छा आता है तो मैं सारा इसी में लग दूँगा. 5 में से 7 नंबर कोई नहीं देगा. 5 में से 5 मिल सकते हैं मैक्सिमम. ठीक है? Do not write in bad handwriting. Doesn't mean you should have a very good इसका नाम क्या है? Correction. जो कि 1 पेज लिखता है 3 घंटे में, लेकिन गजब की हैंडराइटिंग है इसकी. ठीक है ना? तो जरूरी नहीं है कि आपको बहुत अच्छी हैंडराइटिंग है. एंड टाइम मैनेजमेंट. टाइम इज रनिंग आउट. एंड में किसी के पास भी टाइम नहीं होगा. दैट इज ट्रू इन लाइफ आल्सो. सो segregate, set your priorities, what you want to do in life. Practice. Presentation, यार तुम्हारा प्रेजेंटेशन क्यों प्रैक्टिस नहीं करते? जनरल एग्जामिनेशन प्रैक्टिस, बोलो, अपने दोस्तों को पकड़ो, सुन मेरे साथ, है ना? नहीं तो आजकल वीडियोस है, अपने उस पर रिकॉर्ड करो मोबाइल फोन में, उसको बोलो एंड रीड, लर्न, सी, एंड देन यू से अरे यार क्या लंदू आदमी है, कैसे प्रेजेंट कर रहा है खुद का ही. ठीक है? Practice by answering old questions. Old questions first without time limit, then with time limit. First a few questions and then full 3 hours papers. Right? What we are doing in our department is, for the last 3 months, every weekend we give them a full paper. 3 hours paper and they write full 3 hours paper. They've been doing it for the last 3 months every week. Exam is not one time do or die experience. You have to practice. Preparation. Start early. There is no point in delaying exam-oriented reading. Exam की date आएगी तब पढ़ें. ठीक है ना? Be systematic. Plan ahead. Set realistic goals you can achieve and work towards your goal. अभी क्या तुम्हारा aim है? Clear exam. बस. एग्जाम से निकलना है किसी तरह, उसी का वो रखो, बाकी सब एवरीथिंग कैन कम लेटर ऑन एंड कीप मोटिवेटिंग योरसेल्फ एंड अदर्स. ऐसा नहीं सोचो मैं, दिस इज नॉट अ कॉम्पिटिशन, राइट, दिस इज वर्किंग टुगेदर, मेक ग्रुप्स, talk to each other, present cases to each other, discuss topics, and when you grow, everybody grows, right? Time another. And the concept of content and packaging. Uncle chips, 12 अंदर निकलते हैं, उसमें 12 रुपए का बोलते हो, क्या निकलता है? गैस. अंदर खाली 12 चिप्स निकलती है. वही सेम अमाउंट में 1 किलो मिल जाएंगे बाजार में. But तुम लोग खाओगे अंकल चिप्स. Why? Because the packaging, the branding, right? So packaging is very important. The presentation is very important. So your paper should have a structure with the introduction, definition, main part, and conclusion. There has to be visual appeal of what you write. Margins have to be adequate. इतना margin भी नहीं छोड़ दो पेज भरने के लिए इधर 3 इंच का, इधर 3 इंच का. But adequate margin you have to leave. Headings, capital, every question in a separate line. Heading in a separate line, highlighted, underlined. You can make a box. Subheadings, straight away, tab लगाकर. Flow charts, diagrams, diagrams, diagrams. Make the diagram, title it, and label it. If that is done, your paper is done. Neatness is very necessary. काटना है, single line लगाओ. और कट अक्रॉस, ये इसको तुम घचा घचा नहीं करोगे, ठीक है? Then the quality, obviously your matter has to be good, details are relevant. If you want, you can do rough work at the last page, but if there is instruction that you cannot write anything, ओम नमः शिवाय वो सब लिख के और एग्जामिनर को बता दो सर मैंने पेपर में लिखा ओम नमः शिवाय, ऐसा अगर परमिटेड नहीं है, then क्वेश्चन पेपर के बीच में आपको कुछ पॉइंट्स, the moment you see the paper, कुछ पॉइंट्स याद आ जाए उसमें लिखते रहो, ठीक है? If you've written in your paper, then strike out and write rough work. Handle one question at a time. There is a high probability that you might not know the answer to some other questions completely, so do not panic. Just face one question. Focus on the answer you're writing rather than thinking about the next one. Do not think and worry about a question you don't know. If you do not know the answer, leave out a few pages, attempt the next, come back to the question at the end when you play to think and write. अगर नहीं है तो खाली पेज है तो उसको कट क्रॉस करके पीटीओ लिख दो, राइट? एग्जामिनर को नहीं लगना चाहिए कि तुमने खत्म कर लिया, आगे चेक नहीं करेगा, ठीक है? Do not leave a blank, do not leave blank question. Write something at least. Shortcuts and tips and tricks. Prepare on your own notes. मैं क्या करता था? चीटिंग नोट्स बनाता था. चीटिंग नोट्स क्या होता है? सपोजिंग मेरे को चीट करने को मिलेगा और मैं यहाँ पे अपनी पर्ची लगा दूंगा, है ना? या यहाँ पे स्कर्ट के नीचे थोड़ा सा ऊपर किया और देख लिया. Cheating notes right from the beginning make cheating notes. What are cheating notes? These are keywords. जो अपन notes बनाते हैं, these are keywords. What is the key? चाबी मिल गई तो पूरा अंदर का डोर खुल गया. Key notes, जॉन्डिस है ये, तो just imagine कि आपको डॉक्टर नितिन एग्जाम में चीट करने देंगे, लेकिन ओपन में नहीं, छोटी सी स्लिप यहाँ लगा के आ सकते हैं, तो आप यहाँ रख के और जो देख सकते हो, ठीक है? So वो चीटिंग नोट्स के क्या पॉइंट्स बनाओगे, study from that point. When you make those cheating notes, एग्जाम के पहले आपको पढ़ भी लोगे ना, तो आपको सब चीज याद हो जाएगी. In the process of making those cheating notes will cover the whole topic. Master the art of making flow diagrams. बिल्कुल line. ये किया फिर radiotherapy, फिर chemotherapy, फिर so make flow diagrams. Write the category and question numbers very clearly. If time permits, write the question on the top. Right? Rewrite the question. Maintain the sequence with subsections as far as possible. Start each section with question on a new page. Practice speed writing. Exam में 3 घंटे में हमारे resident थे, he missed 2 questions. Why? Because उसको हाथ में cramp आने लगे. पहली बार 3 घंटे लिखना पड़ा. आदत नहीं लगती लिखने की. So start writing, speed writing, and air writing. What is air writing? Air writing is only से हवा में आप लिखते हैं ना my name. So you will see that when you write speed writing in air, it makes a mental image and you'll be able to write faster. So speed writing karo. Warm up. When the exam paper is being distributed, you can make these lines, parallel lines, straight lines, curves, गोले ये बनाते जाओ. वो आपका warm up होता है जैसे रेस के पहले अपन we start doing that. So this is a warming up, scientifically proven thing that when you keep doing making these things, you warm up and you'll be able to write faster and better. ट्राई करेंगे इसका. एग्जामिनर ऐसा फ्रस्ट्रेट हो जाएगा, ऐसा पेपर देखेगा ना, उठा के फेंक देगा. So see to it that your exam paper is clear and nothing can be said about handwriting. Handwriting is the most important thing. In exam, we need speed, fast, clarity of the paper, and it should be understandable. It should not be very good writing. There is debate between whether you need cursive writing or you need separate writing, print writing, whatever you are comfortable in. But कैसे पता चलेगा अपनी हैंडराइटिंग को किसी दूसरे को दिखाओ कि ये समझ में आ रही है या नहीं है, या तुम जिसकी हैंडराइटिंग को एडमायर करते हो उसकी हैंडराइटिंग को कॉपी कर सकते हो. बट स्टार्ट practicing so that you get speed. Begin your first page with good conscious handwriting. शुरू का first presentation, first page तो ढंग से लिखो. इसका मतलब ये नहीं लास्ट पे घसीटे ना लो, but at least first page consciously अच्छी handwriting में लिखो. Spacing should be equal, not too much, not too less. 7 to 8 words in a line. Maintain the same height of small and large letters. Use non-smudging pen. कुछ पेन होता है एंड में जाके वो उसका ब्लॉच बन जाता है और फिर आपका हाथ लगता है and वो सारा smear हो जाता है. So see to it that the pen is not. Don't transfer your stress to the paper. वो किसके छोड़ रहा है कि मत लिखो. आराम से लिखो. Hold the pen properly. Use same pen that you always use. Good grip pen. Not too smooth, not too rough. Don't buy a new style pen from the examination. Practice daily to increase your speed. Else you'll get cramps in the exam. Posture. Sit straight. थकना नहीं है ना. Sit straight. Keep the paper slightly tilted. Normally you are doing this, but when you are writing, you can write like because the arm moves like this, so you can tilt. If you are left-handed, you can tilt the paper like this. So when you are writing, and don't use your wrist to write. No command. Use your full hand to write. That will it will be less tiring. And finally, the first impression is the last impression. Always write in a classified manner. Always write what you know first. Draw, draw, draw. Make flowcharts. Make boxes and clouds. Time management most important, and it has to be neat and clean presentation. And remember, exams are just a phase in life. It too shall pass, and you will also pass. All the best. God bless you.
incomplete assessment होता है जिसमें रीअसेसमेंट करना होता है एंड डायरेक्ट फर्स्ट जो होता है उसमें नेगेटिव होता है सो रिजल्ट के कंपैरिजन में आप फॉलो अप करते हैं. Pirates is the problem. Pirates 0 versus Pirates 12. Which category has more chances of winning? Pirates is because incomplete assessment. Incomplete assessment. 1 0 is incomplete. So you need some there is some doubt. There is some sort of doubt which you need to clarify. Definitely 0 doesn't mean everything is wrong. It may turn out to be normal if you do whatever you want. So the third is indication of diagnostic method. Indication of diagnostic method that patient having love and any love in breast and any love in female breast is indication for diagnostic method. Any age criteria is more than 40 years. Or less than that? Not. USG sonogram. USG sonogram.
Sonography means sonography.
USG both were.
How will you start reading the mammography? So, mammography is not like that, just starting with that lump or what is the tumor you are seeing. So, first you have to assess as a whole breast. So, what is the breast density? Whether it is like fibroblur or whether it is fatty breast. Then you have to see skin or is there any skin thickening or nipple is retracted or deviated to one or more side. Then how is that whole architecture of the breast? So then you can say that there is architectural distortion. So distortion then it is
And
If you do a mammography in a 25-year because that's density.
What other reason can there be? One is dense breast in young females. Another reason, the breast tissue is sensitive to radiation. The breast tissue which is active is sensitive to radiation and can lead to malignant changes later, mutational changes. There are two reasons. Please continue. What are the differences in diagnostic and screening mammography? Yes, I think we have discussed this now. We have discussed it further. So these are the differences, the purpose, the procedure in mammogram, when to do diagnostic and when to do screening, we have discussed last time. So this lady has come post MRM BCS with difficulty in raising the arm above the head, shoulder pain and weakness during arm elevation. What is your diagnosis? You got the question? Post MRM BCS with this symptomatology, patient comes to you after say 6, 7 or 10 days after discharge, comes with this symptomatology. How will you investigate? What you will do? How will you investigate? How will you treat this case? You can give to him now, please. Give to him. Your good name?
Dr. Yashasvi Patel from the SMS Medical College. Yes, sir.
Mr. Kumar.
Sir, most probably it's a post-MRM that could be an injury of the nodules and the centimeters.
Yeah. So the question is, this is your diagnosis, that's fine. How many of you take informed written consent for it before surgery for this sort of complications? Do you really take or
Yes,
we generally
we have taken the consent for that.
So what is the importance of it?
Patient should know about it if there should be a complication like this. So, and after that, post surgery, we can advise the patient for that some physiotherapy for the arm, like exercise of the arm to raise the shoulder and.
Every patient will have some difficulty post-operative.
Yes, sir.
Right? You have to take a consent, you have to tell them, and you have to start exercise immediately post-operative.
So during surgery, what steps you will take that this complication doesn't happen? How will you prevent it during surgery?
Usually the nerve runs the middle wall of the axilla. So during the surgery we have to insert this nerve with a scissor. We cannot use the molecular cautery nearby the nerve. We can use bipolar or either we can dissect the nerve with a metal scissor and so we could prevent the
So cold. Yes.
Yes, sir.
Suppose you saw that now it's cut
Yes, sir.
during surgery. What you will do?
Sir, identify both the cut ends and repair the nerve.
How do you repair the nerve? What do you use as a suture material?
Sir, the monofilament non-adjustable suture, rolling suture.
Rolling. What size?
Sir, 4050 rolling suture.
506. So how do you repair the nerve?
Sir, end to end, I mean the perineural tissues.
What is perineurium?
Peri-
Is a word like perineurium.
Peritoneum, yes, sir.
So how do you do that? Is it the bundle you are going to suture, or it is the neurons?
No, just take the neurons, perineural, both the cut end of the perineural we can suture to and approximate, well approximate to each other.
Can you do it like a wire? You put that can do it.
No,
Like you do an electrical wire.
no.
That's what you do. You do it like this, you do it sideways.
Do it end to end, sir.
So you need to freshen the
Freshen
wire
up the wire.
and then do an end-to-end crisscross sutures. Right?
So if you want to ask something, Suresh.
Just see, you have to always revise the
Revise the
surgery. Mentioned it, revise before doing this. And take only superficial sutures that perineurium should be taken only. Never invade into the nerve fibers. And the orientation should be mentioned. You have to maintain the orientation. Don't twist the nerve. You keep the nerve relaxed and identify the orientation and never twist the nerve.
What is one constant complaint that the patient says after mastectomy and axillary section?
Sir, numbness over the arms, in the part of the arm.
Even if nothing touch, it becomes
Yes, that is
so numbness and altered
Altered
sensation.
So which area of the arm you are talking about? The whole arm? The forearm?
Period aspect of arms.
Upper arm?
Upper arm.
Why it happens?
Because it was also breaker now, so
And okay, so what is the clinical sign that will confirm that it is a serious injury? What is the clinical sign that will confirm it's a serious nerve injury?
bleeding of scapula.
Bleeding of scapula. Next, please. Read the film. Come here. Please come here and read this film. Come here, Vinny. Come here. Please come here.
Well exposed, well inspired chest, chest X-ray, posterior view.
Have you seen an X-ray being done?
X-ray.
That's how do you do it?
So in X-ray there is one projection film and for the collection there is a one lead cassette. The patient, particularly chest X-ray for the posterior view, the front side of the patient is facing toward the cassette and the X-ray is being taken from the projection is from the back. The patient arm is being abducted so that the arm is not coming into the view. And
Everybody must go and see the procedure being done, whether it is CT scan, MRI, endoscopy. You have to go and see. So if you don't tell that the hand has to go around, then it's a big foul.
What is the purpose of putting the arms side?
that both the scapula go away and the exposure of the lung will be more. So, for the X-ray reading, the radiologist will go from center to periphery or go from periphery to center. We have to see the skeleton, we have to see the lung field, we have to see the mediastinum, we have to see the angles, we have to see the diaphragm.
So in this film, the ribs and skeletal appear normal. Bilateral lung field, there is a prominent bronchopulmonary markings. Bronchopulmonary markings. The trachea is into the midline. The spinous process is midline. The distance from the clavicle from the spinous process is equal. The heart is appear normal. The cardiophrenic and the costophrenic angle is appear normal.
This is a male or female?
It is a male breast. There is no breast shadow is visualized.
What is the diagnosis? Normal.
I cannot find. I have not found any abnormality. It is X-ray. This is a normal.
There is no diagnosis for this case.
This is a normal chest X-ray of male breast.
That's great. That's wonderful. So what is the adequate chest X-ray? He has already defined adequate chest X-ray.
So there is to be
No, all this what he said. You said it. Next, please. Read the film.
So this is a contrast enhanced CT scan of the abdomen and the pelvis.
Thorax is different.
Yes, sir. The lower part of the thorax is also seen here. There is free fluid which is being seen around the liver and around the spleen.
What do you call the first cut? The first cut.
The scout film.
So if there is a site is there, you will have something down also. There
Yes.
will be something to see down.
So where is the uterus?
Sir, over here you can see the uterus, the urinary bladder, and
Urinary bladder.
Viva.
Urinary bladder is showing up. Rectum is also.
Sir, this is the posterior and is showing the. This is the anterior portion. This is the posterior portion, and this is the uterus. Bladder anterior.
This is the bladder? No, this is not bladder. Sorry.
There are some masses.
Masses are seen over here.
So what do you say? What is your diagnosis?
Protein and adnexal mass.
With
With the cytosine fluid. All the lesions are seen in the liver part.
what are the contraindications of CT scan?
The patient has any contrast allergy to iodine and contrast, then we will not go for it.
One,
Level
of ultrasound. What do you get?
Creatinine,
What else? Want to add something? Contraindications. What else? What else? So these all.
Where will you see pelvic lymph nodes, specifically ocular lymph node?
Sir, we will have to see near to the internal area testing.
Can you point out where are they? The contrast is most there in the vessel. So otherwise structures will be from above. So external iliac artery, external iliac vein, then below the iliac artery.
You can say in exams that this is not a contrast film. I want a contrast film to confirm the notification. Yes, next. Come. Flash. Dr. Abhinav. Mic please off. Introduce yourself, please.
Good morning, all. I am Dr. Abhinav from Mahatma Gandhi Medical College, third year professor. This is an image just showing the Da Vinci robotic system.
Which Da Vinci system?
Exercise.
Expired.
What are the 3 points that
This is the monitor along with the CO2 insufflation.
This is not called monitor, sorry. This is not called monitor. The first is not monitor. Second,
Second is the robotic console, sir.
this is not robotic console. Second.
The third
It is only anybody can.
robotic arms. These are the robotic arms.
So you have a surgeon's console, which is the patient console or patient card is the mid one, and this is vision card. Vision card. What is the sweet spot in robotic system?
It is the midpoint of the robotic arm, sir. After aligning and docking the when you are able to see the midpoint of the camera port arm clearly without any obstruction.
So what is the significance?
That means the alignment of the instrument.
All the instrument supports are in equidistant. Name the clutches it has. How many clutches are there in the?
2 clutches, sir.
One is?
One is the main adjustment.
What is the name? One is down, another is up. Instrument clutch, port clutch. You assistant minister. Please, sir. Thank you. Next.
I'm Dr. Abhinav.
Please introduce yourself.
I am Dr. Ajay Kumar from nursing.
Identify.
what is this? ETV समझ में आता है.
Innovative.
What are these biomechanical? To give current to the machine, these people ऊपर आएगा, right?
To accept the
Anywhere you require stimulation, so this is what?
Stimulate and
Nerve stimulator. So this is for identifying.
The backbenchers can also speak. They can speak out.
so this is basically the intraoperative used for the intraoperative norm.
Identify yourself first.
Sir, myself, Dr. Swami from the Mahatma Gandhi Hospital, cardiovascular. Sir, basically this is used for the intraoperative norm monitoring. Sir, first of all, it's an example here with the cardiac surgery. We are going to identify the injury of the recurrent laryngeal loss.
So saving how to identify.
Sir, there is 2 types of the intraoperative norm monitoring. First is identify और first एक जो है जो हो चुका है. अब उसमें क्या होता है जैसे जो EKG होती है उसके इलेक्ट्रोड होते हैं. मान लीजिए कि आप recurrent laryngeal loss के आसपास डिसेक्शन कर रहे हैं. तो अगर वो हुआ एडक्शन होगा तो आपको पता चलेगा कि आप मेरे को नर्व से दूर जाना है. दूसरी चीज ये होती है कि अब चलो मान लो इंजरी हो गई तो क्या करेंगे वोकल कॉर्ड्स मिनरलाइज हो जाएंगे तो इसके ऊपर वो ट्रीटमेंट करेंगे तो आपको पता चल जाएगा तो आपको पता चल जाएगा कि इंट्राऑपरेटिव मेरे को नॉन पेरिफेरल करना
Fair. What are the indications? As you said, thyroid surgery. What are the surgical steps of total thyroidectomy?
Sir, after obtaining informed and written consent explain the surgical procedure to the patient, and after saying post-operative anesthetic fitness,
And after checking the required indications of that surgery, right?
under endotracheal general anesthesia, patient can define position.
Anybody want to add on backbenchers on what he said before anything we can do? Before giving anesthesia to this patient? Backbenchers? Software?
So we have
Stand up and
the
say.
indirect laryngoscopy to check the status of the vocal cord.
We have done it previously. We have done it before that. Fair enough. Next. Before giving anesthesia, you want to do something? Yes, you can.
For this marking of incision.
Yes. Why do you want to mark the incision before anesthesia in sitting position?
If we mark incision when the patient is lying down with neck extension, we might end up in doing it it's in too low. Where mark incision while patient is sitting.
Identify yourself.
Dr. Deepak from Mathmanati.
You missed this.
What happens is, if the patient is on the table and you mark it here, right? When the patient comes out, this incision comes onto the sternum. So when the patient is sitting normally, then you mark it and then you do the surgery.
Sitting without extension of the neck. Normal position, not extension.
Why do you want to avoid this risk of the condition?
Steps.
After endotracheal general anesthesia and positioning of the patient, cleaning review. Then incision is given 2 cm above the sternal notch. Then incision is deepened and subclavicular flaps are raised above to the hyoid bone and below to the sternal notch. Then the strap muscles are divided vertically until you reach the capsule of the thyroid.
Divided or separated?
They are separated. They are separated and retracted laterally after giving a midline vertical incision. Then once the capsule of the thyroid is reached, you identify the middle thyroid vein which is visualized, then you divide it. Then you go towards the superior pole of the thyroid. You identify the superior pole, you identify the pedicle and ligate along with the vessels, the superior thyroid artery. And you can make sure you have not injured the superior laryngeal nerve in the Jones tract. Make sure the nerve is secured and then you ligate the pedicle on the superior pole. Then you come.
Go to the next slide because we are slightly late. What is this instrument? Next.
This side.
Ah, you can. Chandan, go. Please.
These are tissue cutting scissors, sir. All scissors.
You ask Mr. Tissue cutting scissor, then after she gets straight or any scissors she can do. What is specific name for this instrument, please? Sorry? Mention bomb scissors. Identify, right? So there are 3 types of it. This is regular, supercut, and tungsten. Last time also you asked the same question. Why this gold-plated instrument? Is it specific for professors only or anybody can use it? There's some specific logic is behind this gold plating of the instrument. Anybody can take. Backbenchers also. I mean,
Supercut.
that is supercut. Why supercut?
More final.
Why more finer? What it is made of? Tungsten carbide. That's why it is gold plated. It lasts longer and better dissection. Right. So that we have discussed. Next instrument. Yeah, please come. What is this? Bolo. Joseph. Pass me your mic. Pass me another question. Please.
Barcode self-fitting.
Sorry?
Barcode self-fitting.
Barcodes. Okay? No, it is not. It is not. Okay? What is this? Barcodes. Yeah. Yeah, this is Thompson's bilateral system plane setup, right? Uses, you can continue with that.
Yes, assistant from more attractive. More attractive, less.
Which surgery? Rectal surgery?
Viva for the
You say upper GI bodies,
Exactly. And upper retrosaccharian, you can access for it. Vilash, diagnosis. What is this?
leukoplakic patch is
Hyperplastic or leukoplakic patch.
Anita wants to say something. Bolo, cause of it, what is the cause of this? On the balance, smoking only? Exactly. So this is a case of
Chutta, that is only chutta smoking. The burning part is inside the body.
and that's why there is a lot of hyperthyroidism during cerebral leukoplakia in the conversions.
Reverse smoking starts. Anybody? Why reverse smoking? Quickly, tell me. Nobody knows the story.
कोई देखना ले
पहले लोग तो जंगल जाते थे, है ना? अगर वो बीड़ी वैसे पिएंगे तो दिख जाएगी तो पता चल जाएगा सुबह सुबह, ठीक है ना? तो वो अंदर वाला बर्निंग पार्ट अंदर है, सुबह किसी को दिखेगा नहीं. समझ लो, that is why this reverse smoke is hard.
Madam, come here and discuss this specimen, please.
It is a specimen showing the lower end of the femur and the upper end of the tibia slightly seen over here. Lesion is seen arising from the metaphysis. Osteoclastic lesion is seen. Here,
Osteoplastic.
solid lesion is present. There are no cystic or any necrotic areas in this specimen.
So what surgery has been done? What is the diagnosis?
Most likely an osteosarcoma.
Great. Can you classify osteosarcomas, histological classification?
So based on the location, they are divided into periosteal osteosarcomas, paraosteal osteosarcomas, soft tissue origin.
Got it?
Based upon the gradings, they are divided into
Histological. So you can read it also. Right?
What is the Codman's triangle?
the Codman's triangle is the new bone formation when it occurs around the tumor. It results into the characteristic periosteal reaction which is seen as layers of bone formation.
Histological first. Sorry, please come. What is the specimen? Come. I pass you now.
Post of specimen of the uterus, which is among the parametric and
They are holding some artery process.
This is like you think it's a normal extrafacial hysterectomy or something else? Type B. What is type B hysterectomy? Which classification you are trying to tell? Which classification is this type A, B, C? Who has given this classification? Five is classification. So type B hysterectomy. When do you say it's a type B hysterectomy? Parametric runs from uterus down to the side wall. So it doesn't mean it's a type B. What else? So that what is it exactly? How much para, how much vagina, how much uterine artery, where to dilate it? What is the indication? Okay. What else? How much vagina?
vaginal margin is upper one third.
3 centimeters. This 1/3, half or 1/3. Uterus diameter, inclined artery, finish. So this is right consideration. So now we have, thank you, you can sit down.
So, during any surgery, what complications you will explain to the patient? The patient is going for radical step. Whether you will take consent for vomiting or not? I'm just asking you one question. Whether you will take consent for vomiting also? So, what is the criteria for that? For what complications you will take consent? You are taking consent for it. What is that criteria? So what is the question? Abhilash?
If there is any expensive disease or if there is any medications which is problem
Asking what complications you will take consent?
minus probability of surgical long chronic pain.
Any significant possibility. Any risk that is more than 1%. So less than 1%.
We'll finish the session here. I'll request Dr. C.S. Mani sir, my teacher, come and take a lecture. Sir is, he wrote things are there, master teacher with us. And so sir is going to speak about how to present clinical examination in the exam. Right?
Like the professor earlier, I'm not going to spoon feed you with how and exactly what to do. I'm going to give you a general idea about how you gather facts, align those facts in a kind of a neat story, and how do you make interpretations based on those facts. So, a lot of your presentation has to be aligned in this way. So, as an example, let me start with this lady who I saw last week. She's a 37-year-old lady who came to the orthopedician for a left shoulder pain of 3 months duration and an inability to lift her arm. Okay? And she had nothing else in terms of positive history. That's all she has. And there is no, obviously, antecedent trauma, fever, etc. So, this, I mean, you guys can jump in and answer as I move along because I have a limited time span. So this is how she presented. So the orthopedician, after doing a clinical examination, found there is tenderness, there is restriction of movement and all that. And he did what he normally does is, take an X-ray of the shoulder. We all see what the problem is. So in this case, we first identify what is the type of margin of the lesion, what is the type of matrix in this lesion, what is the type of mineralization in this lesion, etc. Right? So she's a 37-year-old lady, and so she has something in the epiphyseal, metaphyseal region. And what you see is nostulitic or sclerotic lesion. What is it? It's a lytic lesion. What happened to the cortex? The cortex is completely blown out,
and then things like this. Okay, so what would you immediately think of? Sorry, 37-year-old lady. So you will think of either a primary bone tumor or a secondary bone tumor, right? So we have to, in this case, it fits into what? Primary or secondary? You think it's primary, okay? Why you think it's primary? I'm sorry? No other symptom, okay. Anyway, so this lady had no other symptom. She's a well-educated, she's a manager in some Canada Bank. Alright, so the orthopedician did not think it is a primary tumor and he sends it to us. Please, can you also take a look at it? So we looked at it and we also thought this is not a primary bone tumor. We'll tell you why the reasons are. Anyway, the MRI was done and MRI shows all these features. Alright, and then when we examined the neck and we found there is a mass in the thyroid, alright, of whatever size, and some significant nodes are also there. Now what do you guys think? Parathyroid, you think? Anyway, so it is 6 into 3 centimeters. Normally parathyroid lesions are not that big and they are never palpable. That is the reason when you look at a parathyroid lesion, you always want to do, what is the scan you do to localize the parathyroid? Cystoscopy. So it is so small, so you have to do a digital subtraction scan to even identify where the source is. So normally it is not 6 into 3 centimeters, right? So therefore we won't think of, it can be, you can have a parathyroid carcinoma for all you know, but it's a very rare entity. So what we should always entertain is a common entity. So this is one of the facts that you guys should learn. That common cases are commoner. Okay, so you cannot go look for really rare, odd scenarios when you see a patient, when you confront a patient. So we would normally have thought about possibly a primary in the thyroid. Okay, so and with the metastasis. Although she is a young, she must supposed to be low risk. Here is an exception. Okay, so we think it is possibly a thyroid primary. So what we do ultrasound like we explained already. So that is a screening tool, and then we do this. PET. Why is there a PET indicated in this case? I'm sorry? Thinking of medullary thyroid. I like the idea because of the age group, but I don't like the idea because you don't choose a PET scan for a medullary cancer normally. Okay? You do, here this is an FDG PET scan. Okay? FDG PET scan are for a different purpose altogether. So the idea is good though. So this is the FDG PET scan. We wanted to make sure what are the other sites of metastasis. So what is the burden of this, metastatic burden of this disease? This is what we wanted to know. And is there anything more critical than the humeral head that we just saw? So we did this, and the interesting thing about the scan was they picked up a tumor in the thyroid that was invading into the internal jugular vein. Okay, so there was obvious tumor emboli which is invading into the internal jugular vein. So we decided that we have done enough investigation, let's move on to the treatment. What do you guys think? Is it a good idea or not a good idea? So how many of you would want to have a tissue diagnosis prior? So this is all, you will gain these points. You want to say something? Yeah. I'm sorry. You want a tissue diagnosis? Yes. It's good to have a tissue diagnosis, but here the radiology itself is like a tissue diagnosis because how many tumors would arise from the thyroid, travel through the thyroid veins and enter into the internal jugular vein? So if you read your Robbins pathology, the only thyroid cancer that can do this is a follicular carcinoma of the thyroid. So macroangio invasion. See, in a follicular adenoma, if you find angio invasion or a capsular invasion, you will call that as a follicular carcinoma. But here, I am saying in a regular CT scan, a large tumor thrombus entering into the vein, into the internal jugular vein, and therefore I am almost convinced that this is a follicular carcinoma. Now, if you did a fine needle biopsy on this patient, you're not going to get the diagnosis of a follicular carcinoma unless you took it from the lymph node or from the vein itself, which you're not going to do anything. So therefore, we skip that part. See, this is all how you use your intuitive intelligence to make clinical decisions. So you move to the next step. Okay, so anyway, this lady has to have a surgery in the shoulder. So we'll see whether we can combine that with the thyroid surgery. So that is what we decided, and we posted her for the surgery yesterday morning and admitted the patient on Thursday evening. So the Thursday night, 10:30, I'm getting a call from the anesthetist saying, your patient has a BP of 250 by 150. So if the patient's BP is not controlled, we can't take the surgery, take care of the surgery on Friday morning. 6 o'clock is the scheduled surgery. Okay. So this is the message I got. And I was half asleep. So what do you do? So instantly, I just texted back, please get a calcitonin level and the serum metanephrines. And I go back to sleep. Morning I get the report saying these two are normal. What do you think? What are we getting at? So we are looking at whether she was part of a MEN type 2 syndrome. Okay, this is what we are heading. We wanted to make sure she does not have a functioning occult pheochromocytoma, because the PET scan we did, there was nothing abnormal in the adrenal. Structurally it was okay. We wanted to make sure whether if it is sheer anxiety or it is sheer some other catecholamine release happening. So we checked that and it was normal. And why calcitonin? Because if you want to think about a syndrome with a pheo, then you should think about the primary being a medullary. Then this whole idea about this intravascular thrombosis goes for a participant. So therefore we did that. Calcitonin is normal, metanephrines is normal, and by the morning her BP also is well controlled. So you go ahead and do the surgery. So this is what we saw the morning before, and go to the previous one. Probably not playing. I think there's a video which is supposed to play. Okay, so we could remove the entire specimen and we could take out the intravascular thrombus and clean up the whole thing, and at the same time the orthopedic surgeon also resected and put a prosthesis in the left shoulder. So why we want to talk about this case is about how your clinical decisions are not written in stone, but it is dynamic. It keeps changing according to the information you get as you go along. Your decisions also keep changing. So therefore, all this aspect about decision making should be aligned to string a neat progression of from the history into your physical findings, into your investigations, and then coming to a diagnosis. Once a diagnosis is made, you need to give a plan whether you are looking at if it is malignancy or not, and if it is malignancy, what stage of malignancy are we dealing with, and then you should move on to the goal of the treatment. It should be palliative or curative. So once you reach the goal of the treatment, then we go ahead getting the consent and doing the follow-up treatments. So generally, all this is what is known as logical reasoning in the brain. Okay, now this has been studied a lot, and we have two types of thinking. One is the intuitive thinking, and the other thing is the logical thinking. So you go through many steps of logical thinking. Okay, so soon as we saw that X-ray and we jumped into the diagnosis of a primary bone tumor, that's what normally we should think. But you should, if you go through the logical things, you will see that a short duration, there has not been much of a periosteal reaction at all for this primary tumor, which you planned, you need not have. But does it have the typical giant cell tumor appearance? It doesn't have the soap bubble appearance. And this is coming out of nowhere suddenly, a monoostar depletion. So therefore, you should revise thinking. Am I missing a metastatic tumor? This is the first question you will ask. So the second part which you thought is logical reasoning. Okay, so you need to carefully look at all the list of possibilities and try and see what are the things that is fitting in and what is not fitting into the scheme of things that you are presented with. Alright. So there are several within the logical thinking itself. There are lots of blind spots in your brain, which is called the cognitive fallacies. So there are many cognitive fallacies that we need to overcome. So these are some of the major things. Okay, so we tend to be either overconfident. Sometimes we are fixed on something. You know, you anchor. This is a primary bone tumor. I would not bend and change my views about this at all. So that flexibility, that malleability is missing. And whatever the confirmation bias is something that you will encounter in the exam. Once you some skilled assistant tells you, okay, this is a case of periambular carcinoma, you're so fixed that you want to fit all the findings only to periambular carcinoma, and you don't want to keep your differential diagnosis wide and make your facts of the presentation. Yes.
This is a very, very important point, right? Sometimes you get so, like in a breast case, we had chemotherapy given to a patient, but I remembered that the lump was here, as per my diagram. My assistant said, no sir, we have placed a clip, let us call the sonography people, and then we'll logically do it. I said, no, I'm 100% certain that it will be here, and I'll take out this lump, and then do the thing. But he said, no, sir, come later. The sonography person came, and he marked an area which was almost about 3 centimeters away from which I was standing. So remember, logic is logic, right? You have to go through according to the steps which have been defined.
So, by far, I think the examination should be about two things. One, regardless of your intuitive thinking, go through the logical steps of reasoning. And number two is make sure that we avoid all these cognitive fallacies that we always face, not just in the examination, but in any practical clinical situation into your lifetime practice. Thank you.
Thank you very much, sir, for the enlightening lecture about this.
Introduce yourself and identify. State your names, please, first.
So what is market change and what is modified market change?
Pass it to the next. Next.
So figure 1 is market change, figure 1 is modified. So can you explain?
Anybody knows?
So basically, market change is starting from the starting from the zipper, stay with that, and just 2 centimeters above the umbilical and going laterally towards the angle side. So basically, what is the modification is needed because there is a risk of necrosis over the umbilical, so there is a modification is needed. So the modified incision takes about 1 to 2 centimeters above the umbilical.
Necrosis is the only cause for
Or as well as
the morbidity of getting into one and the process is nice.
The modification allows us to access the fact better for techniques for
And also, You can open the chest.
Yes.
So, can you tell something about the radical qualification? Basic
What?
science.
Critical qualification in one of gallbladder along with the lymph node and liver can be head or can be explored for lymph nodes, how much is the liver. For various section, you will to centimeter margin is required. And lymph nodes are along SDL and right to the head lymph nodes and retroendocrine lymph node.
I'm Dr. Shalim from Bhagwan Hospital. This is a CT scan of head and neck region in a sagittal view, most likely in midline cut. And the positive findings that can be we can see is a lesion over the anterior part of the oral tongue, approximately. So over here.
So is this the best investigation for a tongue?
For a tongue, we use MRI. MRI is better over CT.
Why MRI is better?
So to differentiate between edema and differentiate on MRI to exactly measure the vision. Also to MRI is overall better for soft tissue delineation.
So in which condition you will do CT scan?
If there are localized vision or if we are suspecting any bone invasion, then we will do a CT scan.
And what requisition form you will write for a CT scan of the mouth?
CT scan of neck with oral cavity from base to base of skull to
Anything else you will request? Otherwise, the CT scan.
contrast enhanced. Contrast enhanced.
What else?
Of check.
You don't write PUBG, it's a useless investigation for my. Next.
Your name, please.
Myself, Dr. Viva from SF Medical College, SR. So, this is a imaging of MRI, axis section. This is the abdominal MRI, and the right half of the abdomen is seen in this picture. So, it is upper abdomen, and showing the liver and the renal.
Both above films, the upper one and lower ones are the same exposure.
No, sir.
Airport terminal 1, airport terminal 2, something you remember?
T1 and T2, now you remember.
T1, T2 image is whatever is right, see the T2 image. So, in this imaging, we identify from the CSR, which is showing in the white color, so it is T2 imaging. So, in this, CSR is the land for this T1 image. And, what is T? District principles. Black and plus liver is white, sir, which is mostly the fat suppression liver image. So, we better see the
this comprehensive RA protocol for liver cancer? What sequences you get? What sequences of acquisition you get? Ask. Which is the investigation of choice to prevent liver metastasis?
Triple hit CT we are
Triple CT or MRI.
liver cancer is best identified by the because we also have patient from any SCC or
This MRI. What is diffusion rate in this? What is diffusion rate?
Basically, we are based on the Brownian motion. The motility of the particle that is based on the diffusion rate environment. It is working on that principle and it shows the better differentiation of the lesion in that particular area. And so why the MRI is more useful in the liver because we can if you are planning as a surgeon if you are planning for the surgery the FLR can be estimated based on the volume
What will a CT score over MRI in the liver? CT scan, when is a superior in liver imaging than MRI? That an instance you can say that CT scan will be more informative than the MRI. Any situation you can think of.
CT scans we also see the liver cirrhosis from the upstream of this
Background of liver cirrhosis, you want to look for any transformation of cancer, then you look for an MRI. When they come to you,
characterize the type of lesion or the best of the best differences. Some others are clinical characteristics, especially like metastatic carcinoma has a early arterial and accidental.
so you can come for a diagnostic better in certain instances.
Dr. Deepak.
Dr. Reddy's, the famous with multiple metastasis, normal metastasis, and multiple axial and axial metastasis.
Now, PSL and PSL but कैसे कुछ नहीं PSL में पैट है FDG पैट नहीं और ये बोन्स के नहीं अब नहीं PSL है या फिर FDG is this the reason you said it is tell the reason why you have called this a PSL pet. First of all, why is it a pet? Why not
Welcome, Professor. Sir is facing here. We continue, sir?
continue? Should be correct that this is not understand. Even if they give the evidence, compared to science with them. Okay, so the first field was loss of tissue only bone
mic should be 2 inches.
Variant second one is Teflon coated projector, and third one is laparoscopic transfer for taking the tissue.
Is there any other instrument that you can use instead of the book for the same purpose?
So we can also use the scissor also, and
Third one? Any other instrument that you can use instead of this for the same purpose? Spatula.
There is a folio. Is there I'm Dr. Ashish. I'm from AIMS Oncology as senior resident. The instrument depicted here is a self-retaining retractor, specifically a Balfour's retractor. And
used for?
It's used as a self-retaining retractor mostly in pelvic surgery, sir. Especially when used in conjunction with the bowel pack, it's pretty useful, especially in pelvic surgeries, to stop the bowel effect and have wide exposure in the pelvis.
What is this thing known as in between? What is the name of this?
This is the Viva's part of the retractor.
What is this third part? Yes, what is it known as? 1, 2, 3. First, second, third. Third arm. Third arm.
What additional thing you can use to make your gut away from the
You can use a bowel pack around the malleable retractor, malleable to keep it away.
Next.
Myself, Dr. Sushil from Oncology Cancer Hospital. This is a reusable total biopsy tube. This has adjustable depth, and it can also change the thickness or diameter of the head as per the location we are doing the biopsy. If we are going for a superficial network biopsy, for limited depth, or we can Dr. Sushil Agarwal from Varma.
Myself, Dr. Swapnil from the Mahatma Gandhi Hospital. This is the first picture is showing rectal surgery. The second one is the use of basal technique of sentinel type. We are able to sentinel type.
There are certain words which are fancy sounding and you want to use them. But then it becomes a problem. You can't say this is a sentinel type.
This is basically for check the vascularity of the
What's the thing?
In the second, with the use of ICG light, we are
Don't explain. Anastomosis involving data different. Exactly. नीचे का different.
नीचे से जो सर्कुलर
हिंदी में कौन सा सारा का सारा क्या दिख रहा है, क्या कर रहे हैं, क्या प्रोसीजर है.
basically this is a lower anterior resection procedure in the
तुमको लोअर एंट्री हुआ नहीं हुआ उसको नहीं पता है. इसमें क्या दिख रहा है तो सामने उसको बोलना है.
this is a part of ending.
This command coming out from where? Which part of the head is looking like? The small and the large?
It is the last.
So, what is the arrow showing?
Site of anastomose.
How do you make that way? Leave it. What you do in the next minute? What you are saying in the next?
With the help of ICT, we are seeing whether the vascularity of the anastomotic segment. If it is a vascular or not.
Where anastomosis? Which anastomosis? This one anastomosis is till now. Angle is there. Anastomosis has not been made.
The proximal vascularity of the proximal segment.
So what you are saying?
There is vascularity is present.
Where? Till this area. उसमें system क्या है? That's what. Simple. Which is like me,
गलत बात है.
bias.
गलत बात है.
Didn't have that question, but I can also answer it.
Indications are talking about describe the specific complication can be always the lesion blockage, super blockage, mass blockage, sub blockage. Which identify the structures around.
Right lateral neck nose. This is the MDS specimen that lateral neck nose. And there is a
Total partial, subtotal,
total
Dr. Manish, you have cut the specimen from posterior. Now you are seeing the patient from behind of the right.
right. There is a growth extending from supraglottic involving postcoital involving glottis. Indications are still very not available for definitive diagnostic.
All CLRs,
Not
CLRs,
not available for minimally invasive infections and CTRT. Bulky disease.
what the
T4 disease. T4 disease. Disease involving thyroid and paramedic, cartilage and paramedic.
think it happened with chicken leg. Describe this specimen. Describe it. Without what
These are intestinal specimen.
describe the specimen. क्या लिख रहा है? मुझे कहा था इस एग्जाम में नहीं लेके आना, तो सारे नहीं लेके Okay, I will give backbenchers. You know about this specimen? Who said that? Times. What cell is the?
When I was a relatively younger faculty member, I always wanted to be an examiner. So see, it gives you a feel of authority. You are sitting on this side of the table, and so many young people come and sit scared of you on the other side of the table. But now I hesitate to become an examiner for two reasons. Because sometimes I think if I am sitting there, probably I will not pass. So how can I fail you? Second reason is, it becomes very difficult now at this age and this stage to fail a young colleague, because it is likely to give me either coronary ischemia or atrial fibrillation. So now I prefer more to be a teacher where I can teach and train you so that you do well in the examination. That's my email address, vkkapoor.india@gmail.com. If you want to read more about how to present, how to answer, how to behave, how to do generally in an examination, send me a mail. I will send you the introductory chapters from my book, Pearls in Surgery. There are other chapters also which, of course, cover GI and HPP topics. So if you are interested, you can ask for specific chapters also. But if you send me a mail, I will send you the introductory chapters. So as we all know, that these are the three main components of the exam. I think theory paper will be discussed, and what I am going to concentrate is on the clinical or the practical examination. And that also usually, whether it is MCH or TNB, you have long and short cases, depending on how much time you will be given to work up a case and how much time the examiners will spend with you on each case. What rounds, where case scenarios are presented. Usually these are post-operative cases with complications. And if you are going for MRCS or FRCS exam, there will be some actors. They are not real patients, they are actors who will give you a history because they have been trained to do that. And there may be some spots. So I'm going to discuss only the cases. And long case, it's very important to do time management. Usually you will be told that you have so many minutes. I would suggest that, suppose you are given 1 hour for the case, I would suggest that you spend only about 40 minutes on doing the history and examination, and sit down, write your points down, especially the important points. Think in your mind, what are the likely questions which are going to be asked and how I am going to answer them. As I will tell you later, there are some standard questions which will be asked in every case. You should know how to respond to those questions. Another point is that this is the usual sequence that we ask, that is the history, then we see, that is the examination. But if you find something in the examination which is not fitting in with the history which you have already taken, go back to the patient, ask some more questions. So it's not that you have completed the history and now you can't ask. And then, as I said, you write, think, and after thinking, you may have to go back to the patient and ask or re-examine the patient, and then rehearse the questions which are going to be asked. fast. So in long case, usually the examiners would spend about half the time on history and examination and the remaining half on diagnosis or differential diagnosis and management, which includes both investigations and treatment. And I'm going to talk to you only about history because examination will be covered in a different. These are the usual what we were taught in MBBS components of a history, and still whether you are appearing at MS level or MCH level, the format remains the same and should remain the same because many examiners insist or want that you present the history and examination same way as we were taught in MBBS. So obviously you have the presenting of the chief complaints, you have a detailed history of present illness, and then patient may not tell you, as I will discuss later, there are some associated symptoms which he may think are not important or he may not be having, but you have to ask them. And then we have to do an organ or system review, and since you are all oncology students, obviously a metastatic, detailed metastatic history. Like in any other patient, a medical and treatment history, personal, social and family history, especially if you are dealing with a genetic or a familial cancer or a cancer with familial predisposition. That should be a little more in detail as I will discuss later. Presenting complaints, patient may tell you 5 or 6 complaints. Some patients do tell everything as a complaint, but then you have to sort it out. You have to find out or you have to decide what are the 2 or 3 main presenting complaints and mention them and mention rest later. The duration may not be the same for all the complaints. Patient may have started with jaundice, or may have started with pain and developed jaundice later. Or patient may have jaundice and develop fever later. So, for each presenting complaint, if the duration is different, you should mention that, and it should be mentioned in chronological order. What came first and what followed. Since I am a GI and HPV surgeon, most of the examples that I am going to give are from my specialty, but you can extrapolate the same thing to your other systems also. So the presenting complaint could be pain. For example, a patient with gallstone disease or a patient with carcinoma of the body of the pancreas. The main complaint will be pain. If it is CSecum, the patient may have noticed the lump. Or if it is a retroperitoneal tumor, patient's only complaint or the main complaint or the chief complaint would be that I have felt a lump in the abdomen, and then either really or psychologically patient tends to develop other symptoms. And similarly, you have to find out that what is the main or chief presenting complaint, either single or maximum 2 or 3. There also, if there are 2 or 3 presenting complaints, you have to then decide that from medical point of view, which is the primary presenting complaint. Just to give you an example, a patient with gallbladder cancer, jaundice is the main complaint. And then the patient may develop gastroduodenal obstruction, which becomes a secondary complaint. Because gallbladder cancer, gastroduodenal obstruction is not the primary complaint. Very rare that a gallbladder cancer will present as gastric outlet obstruction alone without jaundice. On the other hand, in a patient with CS stomach, vomiting because of gastric outlet obstruction, which is large volume, usually in the evening, non-bilious, undigested food material, projectile vomiting, the typical of gastric outlet obstruction. And then patient may say that once in a while I have noticed a streak of blood also. So in that case, blood becomes the secondary complaint. On the other hand, in a patient with C. rectum, rectal bleeding may be the primary complaint, and tenesmus and other symptoms may become the secondary complaint. A is a common presentation in many cancers. For example, CA body and head pancreas, CA gallbladder may have pain. On the other hand, many of the tumors which you deal with may not have pain. And it's very important that when you present, many times students say patient complains of pain abdomen for 4 months. It doesn't tell me. If you say pain right upper abdomen, now my thought process is restricted to the organs in that particular area. So it is always better that rather than saying pain abdomen, you say which part of the abdomen. Again, some examiners are very finicky. If you say pain right hypochondrium in the history, they may not accept. They will interrupt you and say, did the patient tell you right hypochondrium? So it is better that you say right upper abdomen, lower abdomen, upper mid abdomen, central abdomen. Try to use as far as possible the terms which patient may have. There is a subtle difference. This is semantics. Pain 4 months ago versus pain for 4 months. Pain 4 months ago means patient had pain 4 months ago, then does not have pain. Whereas pain for 4 months means patient is having pain. So if the history is little long, you need to tell what has been the sequence, what has been the course of each symptom, and what is the current status. It may be that patient started with a mild pain, but now the pain has become severe, or it could be that there was a severe episode of pain, but now there is no pain. So the chronological sequence and the course of the symptoms should be described. In the history of present illness, if there is a long history, which usually in your case would not be there, then as I said, that the progression and current status, and keep in mind that some symptoms which were there, because many patients, since you are a super specialist, will come to you after having been treated at some other place. Always correlate the presenting history of present illness with the treatment history, which you will ask later. For example, a patient with periampullary or pancreatic cancer who had jaundice, but then he underwent an endoscopic intervention, and presently there may be no jaundice. Jaundice has got relief. Similarly, a patient with CA esophagus. Some patients with CA esophagus, they have dysphagia. Once an endoscopy is done, even if it is just diagnostic endoscopy, the passage of the scope itself may dilate the lumen and cause some temporary relief in dysphagia. So you have to keep that in mind and correlate it with the treatment history. Now, once the patient has told you the presenting complaints, then you have to think of what pathology or what organ, what system may be involved, is likely to be involved, and ask the associated symptoms, which, as I said, patient may not mention, thinking that that is not important. For example, if the patient complains of pain, and it is central abdominal pain, and patient has vomiting, you are thinking of intestinal obstruction, so you have to ask other features. Patient with jaundice, you have to mention whether there is history of cholangitis, high-grade fever with chills and rigors. In a patient, now, when you go for the RCS exam, these actors, they know. If I am saying I have history, you don't ask whether I have high-grade fever, chills, and rigors, immediately you get negative marks. You have to mention that. If a patient with dysphagia, malignant dysphagia, you have to ask whether the patient has back pain, which indicates that the posterior parietes of the chest has been infiltrated and it is likely to be unresectable, and so on and so forth. In a patient with bleeding per rectum, fresh blood per rectum, tenesmus, alteration of bowel habits, spurious diarrhea, you are thinking of C rectum. In a male patient, you have to mention urinary symptoms. So it's here, urinary symptoms is not part of the systemic review. It becomes part of the associated symptom, and the place where you mention urinary symptoms is also important. In this case, urinary symptoms should come here, whether they are present or not. And as I will tell later, they have to be mentioned in a group so that I know that you are thinking of infiltration of the bladder, urethra, or the prostate. Incidental history of trauma, very important. When you have a young lady, a lactating mother, and she says, my child hit the head and there is a lump. So in all these situations, you have to use your knowledge, your discretion, your judgment as to whether trauma is related to the lump which is there. It is very unlikely that in the exam you will get a traumatic hematoma which is masquerading as a tumor. Most likely you will get a CA breast, you will get a scrotal tumor, testicular tumor, or a kidney lump in a child. Although the patient or the parents may give history of trauma, but then this point will come in the discussion that why it is not related to trauma. So history of trauma should be asked and wherever relevant, and you should be able to discuss it, that why you are not thinking of a traumatic lump. Since you will be dealing with patients with cancer, anorexia, and weight loss. Now, these days, especially in young people, especially in women, you have to make sure that it is not an intentional weight loss. So you have to use the word that patient has unintentional weight loss of so many kg over so many months. And I'm sure all of you know the definition of significant weight loss, more than 10% over a period of 6 months. If the patient doesn't have a history of 6 months, then 5% over 3 months, and even 2 kg in a month may be a significant weight loss. Also, you have to understand, again you will not get a benign case, but for the sake of discussion, that there are several benign conditions which can cause weight loss, may or may not be associated with anorexia. For example, tuberculosis may be associated with anorexia. Diabetes and thyrotoxicosis may not be. In fact, the patient may have increased appetite. And you also have to differentiate between weight loss because of anorexia, weight loss because of difficulty in swallowing, like in dysphagia, weight loss because the food cannot go forward like in gastric outlet obstruction, or weight loss because of the cancer cachexia. And in general, hepatopancreaticobiliary tumors are more likely to be associated with anorexia and weight loss because of cancer cachexia as compared to upper GI like esophagus and stomach, least with lower GI like colon and rectum, and retroperitoneal tumors usually do not have these symptoms unless the tumor is causing postprandial fullness because of compression on the stomach or intestinal obstruction, which is not very common. Negative history also is important. As I mentioned, if a patient has jaundice, you have to mention whether the patient has pruritus, high-grade fever with chills and rigors, and they should be mentioned in a sequence in groups. So when you say a patient with loin pain, you should say whether there is history of dysuria or hematuria or not. Patient who has upper GI bleed, hematomesis, marina and hematochezia should be mentioned in the same sequence. So your presentation of history should be like a story which is free-flowing, which is organized in a chronological sequence rather than just words and phrases. Now coming to the metastatic history, which is very important for you. Many students commit this mistake. They say that when describing metastatic history that there is no jaundice. You should remember, liver metastasis very rarely cause jaundice. They will cause jaundice only if there is a large metastasis sitting at the hilum of the liver, which is causing conductal block, either the vein duct or the confluence, or extensive bilobar liver metastasis which have replaced most of the parenchyma. By and large, liver metastasis, even if they are multiple, they do not cause jaundice. The only symptom of liver metastasis is anorexia and weight loss, which can be there even without metastasis. So there is no specific symptom to say that there are liver metastasis. On the other hand, in lungs, yes, again, many students say there is no history of hemoptysis. That is not a common presentation of a lung metastasis. The commonest presentation of a lung metastasis is asymptomatic. It is picked up on a chest X-ray, chest CT or PET scan. If at all there are symptoms, dry irritating cough because of bronchial irritation is more likely. So you should mention that. Similarly, pleural metastasis is more likely to cause chest pain or shortness of breath because of a large malignant pleural effusion. In bones, it is recent onset bone pain and spontaneous fracture on trivial trauma. And in the brain, again, it is not convulsions. Convulsions occur much later. It is recent onset, persistent, moderate to severe headache, then vomiting, visual disturbances, and lastly convulsions and unconsciousness. So your metastatic history should be in detail and starting with the earliest symptoms and then going on to the symptoms of advanced metastasis. Medical and treatment history may be important in even making a diagnosis. For example, an elderly gentleman who has upper abdominal pain and has severe anorexia and weight loss, and he also says that I have recently been found to have diabetes, immediately you start thinking of a pancreatic cancer. Upper abdominal pain with anorexia and weight loss in an elderly gentleman can be anything. It can be HCC, it can be pancreas, it can be stomach, but absence of GI bleed, absence of dysphagia or gastric outlet obstruction, and this history of recent onset diabetes points that you should make a diagnosis of CA body of pancreas first. Antiplatelet drug use, very common in now middle-aged elderly people who have coronary ischemia, is not important for diagnosis, but it becomes important for management. When you are preparing the patient for surgery, if you don't say that I will have to stop these drugs for at least 5 days, change over to injectable heparin or low molecular weight heparin, then it becomes a negative point. Patients who are on steroids, not only you have to give perioperative cover, but you may have to be careful about whether you will do your primary anastomosis or not. For example, a patient with FAP, you can't do a pouch sorry, ulcerative colitis, you can't do a pouch. Obviously, you will not get a case, but you can get a case with ulcerative colitis and a superimposed malignancy. The patient who's on steroids, even those who believe in a single stage pouch will not do it. They will do a colectomy and do the pouch later once the steroids have been taken off. Personal history should be in little more detail because they are related to the etiology. So, if a patient is a smoker, you should mention packet years, and many students say that he is a social alcoholic. There is no word like social alcoholic. Alcoholic means alcoholic. A person who takes a defined amount of alcohol over a period of time and who's not dependent on alcohol, regular intake. You can use the word social drinker, but you can say that the patient consumes alcohol as a social habit. Now, this is important that all cancers which are genetic, familial, hereditary, or have even a familial predisposition, you should not only take detailed history of a suspected or a diagnosed or a treated cancer, of death at a young age, even if the patient doesn't know the cause, because the commonest cause of a death at a young age, if there is no history of trauma, will be a cancer of first degree relatives and in some cases even second degree relatives. So grandparents, parents, siblings, children, aunts and uncles, both maternal and paternal, you must take a history and all of you should know how to draw this family history chart. So once you have finished the history, these are some standard questions which will be asked. Summarize the history. Many examiners would stop you at that stage and ask you to summarize. You should mention all positive points and important, related, associated negative points also. And then they would ask you, what do you think, what do you make out of it, what is your diagnosis. Now you know the examination findings, but at this stage, you should forget that and you should discuss only based on history. There will be so many cases where based on history the diagnosis is something else, but after you have examined the diagnosis is something else, which may even change after the investigation. But you should have the thought process that you isolate the history from examination and discuss at this stage. That is why once you have taken history, you should stop. You should think what is going on in my mind without going into examination. I would not go into the examination in detail, but just a few points. In the general physical examination, performance status, because even if the tumor is resectable, if the lady is being brought into your clinic on a wheelchair, then she's not fit for a major surgery like esophagectomy or a pancreatic urothectomy or hepatectomy at this point. So performance status, nutritional status, look very carefully for pedal edema, look for nodes which are related for abdominal cancer, left supraclavicular node, or rectal cancer, inguinal node, epigastric lump in testicular tumor, and if you are thinking of a possible diagnosis of a lymphoma, all nodes in esophageal cancer, all cervical nodes are important, not only left supraclavicular. So the node which you mentioned should tell me that you know which nodes you are looking for. And a simple test like breath holding time, how many stairs, flight of stairs the patient can walk, tells you a gross estimate of the respiratory reserve of the patient. In the abdomen, look carefully at the umbilical or a nodule, obviously lump. Liver should be looked for and described, presence of free fluid, and either you do, or if the patient doesn't agree, or if you are told, you should say that I wanted to do a per rectal and per vaginal examination, and this is what I was looking for. I was looking for a mass in the rectum, I was looking for a deposit in the rectovesical or rectovascular pouch, I was looking for the finger stall, whether it has yellow stool, whether it has melena, or whether it has fresh blood. So that tells me that even if you had done the internal examination, this is what you were looking for. Again, at the end of examination, you may be asked to summarize the examination findings. Listen carefully. Now I am asking you to only summarize the examination findings, not the history. And then I can ask, sometimes what happens if you are given 4 wrong cases, you have done reasonably well in the first case, in the second case, the examiner will say, "Acha, isko jaldi se batao." So then you should be prepared for that. Then you don't have to present in great detail. You give a summary of the history, you give important points in the examination so that you can come to the discussion of diagnosis. On the other hand, if you are asked to summarize the case, then you have to give a summary of history and examination, and again, the diagnosis. By the time you reach the stage of diagnosis, in all likelihood, there is a good chance that you may pass. And depending on the history and examination, you may either give a diagnosis, for example, you can say it is CA best, or you may have it to give a differential diagnosis, but don't enumerate all the possible causes. Those are the possibilities. They are not probabilities. That is for curing paper. Here, not more than 2 or 3 possible diagnoses. There are some cases where there will be no diagnosis. For example, an elderly gentleman, upper abdominal pain, anorexia and weight loss. You can't take a diagnosis. Then you should discuss that which organ or which system is likely to be involved, what is the likely pathology. In your cases, usually it will be malignancy. Always make common diagnosis first. Don't make a rare diagnosis. Don't make a diagnosis of a cystic neoplasm of the pancreas based on history and examination. That is an ideological diagnosis. So there are some diagnoses which you can't make on clinical examination. In a short case, short cases are usually in the Royal College exams. You are asked to examine, and while you are examining, you have to keep describing. So you are taking history, your examination, and you are describing because the examiners are standing then and there, and they keep on asking the questions. Usually the questions are, what is it, why is it so, what else you would like to do, and how you would like to manage. So this is a book which I mentioned. There are a few chapters which are general instructions to the candidates who are appearing in the exam. Send me a mail, dkkapoor.india@gmail.com. I'll send you the initial chapters. If you like those chapters, you can ask for organ-specific chapters also. Thank you.
Even they are partly addressed, the consistency is what is hard and very social. And yes, using those mid-physical tumors, eccentric lesions are there. If you look at this, they should have a sort of circumferential expansion lesion. Okay. This probably most likely looks like a bomb. So the question here is how do you we generally perform the bone middle biopsy. If you plan future surgeries that you that prevent biopsy should be done, that is not doing that incision. Would you like to do the biopsy under some guidance or unnecessary? You see that biopsy is also better. But if we can yourself check that it is a subcutaneous swelling. Yes, sir. So all this better, but we can perform directly.
You said it is a soft tissue. This is called soft tissue. You said sonography. Suppose it's a bone part swelling. Then how will you do sonography or a biopsy or
the advantage of sonography that we can
with the bony swelling. Question is with the bony swelling. Bone swelling, great. Ultrasound, soft tissue,
the bony swelling is exactly the same location.
Yeah, this is the bony swelling.
How do you biopsy? So there is a special needle for that. We can do we have a name for generally.
So you want to use USG guided bony swelling?
No, sir. We can appreciate the swelling.
It is appreciable swelling.
We can perform the directly. We can perform the
anything else? Or you want to image it first and then do biopsy? You want to do biopsy first and then image it?
Imaging should be performed prior to biopsy. Why? After biopsy, there is architecture changes. There may be some artifacts may appear.
Why is the artifacts after biopsy?
There are inflammation. Most biopsies are hematoma will be there.
Yeah, that inflammation. What's hematoma? Then
what imaging would you perform for this patient? Sir, MRI would be better. As it is soft tissue sarcoma, I'm suspecting to be soft tissue sarcoma.
then suppose it's a bony swelling then?
Then CT will be better.
Sure.
First of all, X-ray should be performed.
But if it's a bony swelling, MRI CT or MRI plus CT or something else along with MRI CT, it is a bony swelling.
MRI plus CT.
Right.
If agents will be appreciated, marrow involvement, extent of marrow involvement will be appreciated. Why is better? Much better.
or did MRI with CT instead, I'll say MRI with an LCD. Okay, CT I don't think is going to get you any additional information. MRI is sufficient to tell the soft tissue extent, the muscle invasion, the neurovascular involvement, the muscle invasion. Okay, and an X-ray definitely you need for any sort of gross characterization of any bony tumor.
Suppose I say this is the osteosis.
Why don't you want to do incision biopsy that will give you more tissue for why don't you want to get an incision biopsy? Just open 2 centimeter, take a tissue and close it. It will give you more tissue for your ISA. Why more is preferred over? Why do you prefer core biopsy over incision biopsy?
Is core biopsy less invasive?
So we will be treating skin less. Both vaccines less.
You don't need any switching, you will create less structural defects to the area of the surgery.
Spillage will be less, bleeding will be less. Straight, you can exercise during your final surgery. That's the advantage of core biopsy. And histopathologically, if you compare the results of core biopsy versus incision biopsy, is almost same.
Core biopsy tissues well enough to create all sort of markers.
What is tripartite phenomenon? What is tripartite phenomenon in large soft tissue tumors, large bone tumors? Anyone of backbenchers also can attempt these questions if they not able to answer. So the tripartite phenomenon is a large tumor. You take biopsy from different sites, you will have different histopathologies. That is known as tripartite phenomenon. So this is large bone or soft tissue tumors.
What kind of information do you get from MRI? Apart from this is the lesion one. So what kind of
Development of different muscles compartment, neurovascular relation of neurovascular development.
Can you have any brief idea of histopathology also? What pathological type of tumors?
malignant versus benign or hybrid versus low grade? Can you get this kind of information?
Very well see, also you have given T2 sort of things, so you can see that this color contains fat and even the myxoid material comes with it. So, liposarcoma and myxoid variant of sarcomas, you can make to certain extent that pathological diagnosis on base of the MRI.
And hence, soft tissue sarcomas and high potential of lymph node metastasis.
Silent sarcoma.
Townsend sarcoma, alveolar soft part sarcoma. There's a common histology which we have in lymph nodal metastasis.
So the biopsy, if the pathologist reports presence of round cells, what information you are getting, what can be the possible pathology?
answer based on the age.
So can be possibility to scale it?
You should be aware of like many IHC markers for some tissues are on those basis of at least you should have basic idea. You should not be dependent on the pathologist that just reading the last line so without so at least you should have a basic idea. Then next thing is I think to rule out the distant meds. What kind of invasive? Is there any need of abdominal imaging or not?
Fine. This is one kit or there is something different out there? Is it kit of one biopsy type of needle or there is something else? Name them. Anybody wants to attempt this question? Can you name these three types? No? Third one is the upper se third and नीचे से third. That is automatic. What is
ऑटोमेटिक में सबसे ऊपर वाली क्या होगी?
बीच वाली क्या होगी? This is on the side cutting sugar biopsy needle, and as you rightly said, this is why, there's a lot of buzz about robotic surgeries and all that really going on, especially pelvic surgery, mediastinal surgery. So what advantage robo gives to when you are operating in case? Freedom for the patient or surgeon? What sort of freedom? He's moving around having tea, coffee with colleagues there. This is what you want to say about the freedom? Or you want to add something to it? For the surgeon or somebody else? These are some advantages of robotic surgery. We need it, right? So what is the advantage of robotic surgery? Anybody can attempt it, somebody. You can these guys. You never have a question, somebody can take a question. Laparoscopy also you can do. Laparoscopy also like the wonderful business. What is this movement one? The 360 degree one advantage. The instrument can move around 360. Whereas laparoscopy only. Next advantage. Sorry? Go and ask. To whom? To patient or to doctor? Surgeon? Surgeon तो laparoscopy करेगा तो भी stabilize रहेगी. Sitting तो भी stabilize है. If you open the he also stabilize. Surgeon can only do surgery once he is stabilized. You want to say something? You come up with the term. He said something. He whispered something. What is that? Tremors are not there. It's not. It is filter. Tremors may be on your joystick, but not go there. So there is no tremors. Second advantage. Third advantage. So why it is a need to have a 3D view and it is most important in which part of surgery? You are doing hemicolectomy, you are doing radical hysterectomy, or radical prostatectomy, or radical cystocystectomy, or in radical pelvic surgery, or medicine. Why 3D view and where it is most important?
Narrow and deep spaces will be very helpful for surgeon. Better visualization of structures.
Spatial distance between the structures can be clearly visualized and you can operate on better. What else? No labs will be better. What else? What is the major 4-5 things which Robo gives edge over the technique? Yes? Predictions are? Telesurgery, good point. So what is telesurgery? In the car, sitting in the car, into surgery in Manala. Can you clarify for make it more clearer for everyone? What is telesurgery? Open surgery lab also patients in operation theatre. That is like. So that is, I am sitting here and doing surgery. There is a telesurgery. Different instruments. What else? Advantage. Actually, what is the advantage of the vaccine?
So, telesurgery.
There are a lot of new things happening in the surgery, which you can learn. The most important thing is
Precision.
come on. No, I know. You guys know you just figure out.
Precision.
Precision. Bloodless. How much is the magnification in robotic surgery? Go no. 10 times. That makes a difference. Huge difference. So name the instruments now. आपके पास था? बोलिए. आपके पास था बताओ. Name next anybody can try. So what is this first? Showing this. Scissors. So you can say scissors. Robotic arm scissors. What is that? What is this? Interstate. Yes, tipped. Right? And then third one is. So there are 8mm instruments. As I said, monopolar curved scissors, hot shears, also known as hot shears, tip up fenestrated grasper, and a magnet bar. Next. What is the name of this instrument? उसको नाम लगाना है इसका. पूरा बाहर एक नवीन एस्टेशन है. So what is it? Swab on stick. Sponge holding process. Can you give that sponge holding process, sir? What are the name of the, just name one, please come here. Name the parts of this instrument.
This is the shaft of the instrument with interlocking ratchet with the box type of the joint, and this is the grip. This is the keyboard with the grip.
What are the uses of this instrument?
So it is long in size, so we can use as a painting, so we can measure the patient. It can be used during the surgery to hold the gold medal or any
Sheets. when you do a radical cholecystectomy, what is the after opening you assess everything is fine laparoscopically, you open the case, and then what first step you will do?
So I will first extended polarization and interaortotubular dissection. We will send it for the
What are the boundaries of your interaortotubular dissection? That is which group of lymph node?
It is 16.
16. Boundaries of 16 PR.
16 is superiorly it is extended laterally to the left renal vein, and we will excise the tissue
From left renal vein to so why you want to do biopsy there at that place only?
So it is not if it is positive, then we will consider it as a L1 disease. We will not, and cancer will be failure.
So it's a 16B1. B1 and B2. 16B1.
What are the other group of lymph nodes you remove in radical cholecystectomy? Thirteen is what? Yes. And 14 is what? 17. It is not middle poly. 14 is not middle poly. 17. Superior is what other group of lymph nodes you remove in radical cholecystectomy? That's still left. Deepak? He said 12, 13, he said 17, he said 14. 8 is what? Yes. And station next to it is 9. 9 has to be. Suppose you open the case and you find that the unsusceptible is a mass there on the celiac axis. This is not unable to remove it because it fixes it. So what other thing you can do at the same moment during surgery? It's a palliative now. Please give us some name. That's fine. मैं से गलती हुई मैंने बोल दिया but now say what we can do extra. What is a mistake रहेगी?
Palliation item jaundice तो है नहीं तो jaundice का prophylactic weekly recurrence को करते हुए period of pain कर सकते हैं.
How do you do it? Alcoholization. How do you infiltrate it? Turn on the signal. Keep competition. So the parts are as rightly said, the shanks for jaws, then shanks, then boxlock, and the chest, and the ring hands. Yes, madam. Come to the screen. Good. Sir, ask something. That's a difficult question, sir. So everything is fused now. Right? So we can say everything is fused. What is fused? What is fused? What are you talking about? So it's an
What are the points in favor of it being a mostly sarcoma?
So the location of the tumor, there is periostal elevation.
Can you mark it with your fingers? This elevation is only on that side or any other side? Only two sides are there for periostal elevation. This pharma जो tumor is periostal elevation सभी जगह होगा.
What is the radiographic shadow seen around the tumor?
What is sir asking this point? What is it asking?
The radio-opaque shadow seen around the shaft of the tumor. Why is it radio-opaque? This is not the bone, right? It's a soft tissue around the bone. Why is it radio-opaque?
So what is it? So there are two arrows there, right? You can see there are two arrows there, right? So what is the first arrow and what is the second arrow showing? It is seen in the second also. Anybody can take a can help her also.
Watchman triangle.
You've seen an X-ray of osteosarcoma.
It's at the diagnosis.
Quadrant triangle.
What are you doing?
Periostal elevation is quadrant triangle, the upper arrow. Which was the
Periostal.
What makes it as final diagnosis with radiology? And the age and location. What do you want to do next? Is the next the patient came to your OPD, showing his X-ray, and one have a pain and a swelling in the limb, and then next, what do you do next? Take the window, HDMI examination, so you look speak.
along with the local MRI, would you like to get a chest X-ray for this? Like to get a chest X-ray or go for a CT test? You would like to go for an X-ray first? See, if the chest X-ray shows canal form metastasis, would you like to go for CT next? So, with the chest X-ray, you're exposing the patient to less radiation compared to a CT, and you're getting the same information that is metastatic, right? There's always a step ladder when it comes to investigation. So you start with the lower and then you climb upwards.
Chest X-ray is normally what you want to see test.
Why?
Chest X-ray is come now. You want to see chest. Alright. So the smaller nodules are like 5 millimeter, and the radiologist says it may be a granuloma or a metastasis. What do we do?
Get a CT to see
There's only said the smaller you said smaller metastasis cannot be picked up on CT. That's with chest X-ray. What other indication other than the size? In X-ray, which cannot be picked up on X-ray, the met is there in that area. What other areas? The black area in X-ray. Where it is even slightly 1 centimeter, you are able to see that. Soft tissue you can see easily. What other areas? Angles, orthodontic angles. Where you can miss a larger point also.
What do you like to do?
after imaging, we get a biopsy done along the incision line, which is
This will be the incision line.
the neurovascular bundle?
It would be posterior.
Posterior.
Where is the adductor canal? Where is it?
Medial.
Medial. So that's where the neurovascular bundle is. So your biopsy will be from the, don't do it from the lateral side, although the human may be accessible from the side as well.
So, do you really do a bone scan in case someone says osteosarcoma, you have MRI, MRI side, you have X-ray, and this put an MRI? Do you really do a bone scan? Is there any indication of doing bone scan in these cases, or there's no need for bone scan, you straight away go for whatever treatment? You would have bone scan any indication in these cases? Osteosarcoma, yes. But yes, why?
Do you think there is something called a primary osteosarcoma and a secondary osteosarcoma? Is there an entity like that? Primary osteosarcoma and a secondary osteosarcoma. There is. So in the secondary, what actually happens? There's a pre-existing benign lesion which transforms. The pre-existing benign lesion will be polyostotic. So let's say you have a enchondroma or something. It can transform whether it is chondrosarcoma or endometrioma. Exostosis. These are all multi-diseases. Okay? So one of them will transform.
In a case scenario, so the question for you is that patient comes to you and they just tell you to diagnose osteosarcoma. You have to discuss the treatment plan of this case with this patient. How to discuss these things. You are examining, you have proved osteosarcoma is to go through and all the investigation states with localized disease. What we do now? Treatment. Discuss the treatment with them. How you discuss it. Okay.
Forget about others, just you are sitting in your OPD and you are seeing this person.
Yes.
Jenny, this is about how you communicate bad news to a person. Okay, so let's say this young man is 70 years old. So, okay, that's why I call that age. 17 years old, he's just finishing school. He played in his football school team, came with a pain after an injury. Okay, so you took an X-ray, that's what you saw. You've done the biopsy, everything, and you know it is osteosarcoma, non-metastatic osteosarcoma. Now you have to break the news to the kid and the parents. Nitin is the parent.
Yeah.
So you want to save 90 anticipation? Oh. Sorry.
There is no forest range research. There will be link salvage we can achieve. You cannot achieve link salvage. In this case, we will ask about electricity. In this case, we can compare, we can go for link salvage.
What is the principle of treating this case? Sorry?
Chances of myelocity followed by
The principle is first treat the microscopic disease. Listen to the CT chest diagnosis. Also, what is the most important prognostic factor we have in this team? Sorry? Absolutely. So, how will you find out human necrosis? You operate in there.
Another scenario, this patient, you do a CT check, this patient has 3 lung nodules, 2 in the left and 1 in the right. What would your intent be? Curative or palliative?
potentially cure. Potentially cure.
If the number of lung lesions is 7, then
Potentially cure.
still
Still potentially cure.
is there a cutoff for oligometalstatic in pediatric hospital?
I'm saying that the 7 modules were picked up 2 years after the treatment. 2 years after the primary treatment.
So does it make a difference in like 2 years survival versus still bonus metastasis?
The difference in survival between synchronous and autonomous medicine.
So metabolism will have better potential. So if you are sleeping for us, still nice. Then obviously you can think of that these may be potentially curative options, but then you have to assess the disease biology, what is the response to the chemotherapy, then you might consider. Otherwise it might progress during chemotherapy also. So then
SR is saying that you have given chemotherapy. How many cycles of chemotherapy and when you want to assess? Or any indication of doing surgery before completion of chemotherapy?
The regimen of choice for this. Even in oncology, you have to remember some common chemotherapy regimen being used. So how many cycles of chemotherapy you reassess, you reevaluate those patients?
The problem is assessment of response in our there a problem in assessing response? Can you assess response in the radiology imaging? Response is always from pathology. Can you assess response by radiology?
Yes, sir.
Whose voting system is there for connecting on the basis of
Based on recognition of the on the merits.
Very good, but it is not so foolproof. The problem here is because the tumor is mostly composed of matrix and less number of cancer cells. Even if there is a lot of necrosis from the cancer cells, the matrix will remain unchanged. So therefore, you will not see the tumor shrink. And that is the reason why the assessment of response in bone tumors are becoming very difficult. Although there are other criteria, lots of radionuclear scans and other things that are coming into view to assess the response. It's a tough thing. So always pathological response is the final call. And that's why you need to go through those number of cycles of chemotherapy without requiring to assess it. But progression is not it. If the patient's symptom will be pain, pain is not coming down, or the swelling is actually increasing in size, progression you should not miss. But you can be easily, it will be resultant to assess response in a whole gene.
If you want to do limb service in this case, what is the steps of limb service? Thanks. Sorry. Steps of limb service.
Perform the we have to resolve the dissection, primary dissection of tumors with oncological principle and margins. Then reconstruction is in this case we can go with the prosthesis steps. First, this is the principle of the steps of limb service.
You write 40 notes. Step 1, step 2, step 3.
You are the operating sir. Tell us what will you do.
Sir, under anesthesia after painting review we should take new place.
Which anesthesia will you use for this patient?
Sir, under spinal anesthesia we can proceed. Spinal anesthesia we can proceed. Skin is no lateral aspect of normally placed.
Lateral aspect of
Knee joint, lower
we
thigh.
had just now discussion about the where does it go around. So total is in the lateral aspect.
Medial aspect.
size of the incision
Backbenchers, incision कहाँ दे रहे हैं? What length of incision? Which aspect?
Any of you please get up and tell me the lines of the bone cuts in this picture. Lines of the bone cuts.
He is the HOD or the assistant professor there will be cut. But in the anteroposterior to this one higher. But 2 weeks. In this, where you margin positive and even margin positive.
You want to take the help of MRI scan to see the memory length there, how much is getting involved.
So you have to say as a but you can say the lower extent of it. So you cannot say you want to MRI for the lower extent. You want to do disarticulation for this piece? Disarticulation is this level, knee level or somewhere else? Knee level you do disarticulation. What is the requirement of disarticulation at knee level? Knee level disarticulation. What is disarticulation? What is? Knee disarticulation. Disarticulation, we're talking about disarticulation. This makes lower head look out.
Your stainless steel process is all the TK contact, which is very nasty.
You have to take out the knee joint along with the tumor with the safe margin. What do you do when you do a resection? You do a resection of the femur out. Anything next step? हमने कहा कि केस स्पेसिमेन अलग कर दिया. Next step. Or during surgery, the back we have to check the marriage. How? So you have to go for the correction of the marriage. And then put the prosthesis and proceed.
So there is some sort of confusion. When we do knee replacement, do you need to cut the tibia also from top? No? So how where will that prosthesis remain? Because it is a joint there. The prosthesis is not just the femur. It is that joint all the time. Then you have to make a plate on the tibia. That prosthesis fits on that. And that one joint is not very important socket, but it is a different type of a joint which gets stuck both into the tibia. Otherwise, you can't just hang it there. It won't be still.
this was
A single patient or different?
different patient.
पहले से पता है क्या? पहले से पता.
So read the link properly. We don't want to diagnose. Read the link properly.
किसमें ये नहीं फिर अगला ये नहीं है ये वाले बोर्ड है the better the breast is more the fattier it is. So increase the density, increase in the fibrous number and the glandular tissue. More the stoma is more the darker the breast, more the glandular tissue, more the density.
So what is this getting known as? What is this here? Cancer. We have the first one. How would you present it? Say one class to find the showing lower chest and abdominal pelvis. Name this all the structures shown in this. Name all the structures shown in this. Point with your finger. This is the target. All the organs need to be identified on this. Everyone is. So what is this? Which column? Right side. What is this?
Image is too small.
You don't identify it. I this small image.
How can take sagittal or orbital curves use it takes software in the you can take frames only in the experience. So it is software it uses the experience.
Where is the bladder urinary bladder? Patient comes to you, 50-year-old male comes to you with muscle invasive bladder cancer. Right? How will it proceed? Patient is diagnosed muscle invasive bladder cancer. Will you present the burden first?
My
deal with your cases as come as a muscle liability.
PCT chest, PCT bola form, roll out metastasis. That is a localized disease. And there are two protocols of procedure and
what is like muscle invasive bladder cancer? Have you defined the histology? Then this squamous also can be DCC. So you have to classify your things. What is it? Then we have to
How do you confirm cancer is muscle invasive in the bladder? Remove the tumor from the base, take a specific muscle biopsy, and that muscle should show infiltration because if you take it with a specimen, the superficial layer of the muscle, which is part of the mucosa, would also be there. So we have to take the muscularis propria of the bladder, and invasion of the muscularis propria is what would be called as muscle invasive bladder cancer. BCG act as opposed to chemotherapy. What does BCG do and what will chemotherapy
Sir, ask something.
The difference in the action between BCG and the chemotherapy agent in bladder cancer.
Take a mic up and speak louder, please.
Supervision bladder cancer. That is for systemic action. BCG is for local action. BCG works by inflammatory reaction. This works by anti-neoplastic action, isn't it?
So now my question was muscle invasive bladder cancer. What will be the next question you want to ask to yourself to further go for the treatment? What will the next question? So you want to know the histogenesis. What type of histology? So what are the type of histologies are there commonly? Cognasis, TCC, then squamous and then adenoma. Right. Now it is adenocarcinoma, muscle invasive. What do you do? Adenocarcinoma? Anybody got to take? Realistically, adenocarcinoma bladder.
What is the meaning of adenocarcinoma? See, the squamous cell carcinoma, we can think there was some stone helpless disease earlier or some infection which gave rise to the squamous cell carcinoma. Similarly, if you see adenocarcinoma, what is your first impression? Because you're not supposed to get glands within the bladder. And if you get glands, you can get an adenocarcinoma, isn't it? So what is the meaning now? Exactly. So usually your adenocarcinomas are the fundus, which is part of the raffia element. And therefore this has a different biology altogether. And your treatment also would be totally different.
Now this squamous cell carcinoma. What do you do? What cell? What radical cell? is 1 centimeter lesion at the level of the apex of the bladder, squamous cell carcinoma. No lymph nodes. Amount of dissection of bladder will depend on the size of the lesion and location of the lesion. There are two criteria. In multicentricity, it is there in conditions of carcinoma. So what is staging cystoscopy? And when do you do it? Have you heard about staging cystoscopy?
Yes.
No.
Remember, urology you usually leave it out and out of course. That should not be the right?
Sexual conscious please.
See the residual lesion up to your brain. See the residual lesion up to the your brain.
After you have after the follow-up, you want to say follow-up later.
So upper tract urothelial cancers, they don't do staging cystoscopy. We do a staging cystoscopy in cases of upper tract urothelial malignancy.
You want to do staging cystoscopy in bladder tumors, PCCs.
We would, but also in cases of UTUs.
Okay, what are the indications of staging cystoscopy?
So muscle invasive bladder cancers. And incomplete first sampling after TYPT if they have not mentioned on the deeper biopsy. Then we do a staging cystoscopy and an upper urothelial, upper tract urothelial for a staging cystoscopy.
No. The three cases where in a cystoscopy, you use a tumor, you do a TRBT, you have to do the staging cystoscopy, taking biopsies from different sites. What sites you will take biopsy from? Wherever there is a litigious lesion, there you have to take the biopsy to rule out carcinoma inside. Why you want to rule out carcinoma inside? Because it is a high-risk case for recurrence. And that's why you have to do a staging system. So, and now this is TCC, confined muscle invasive bladder cancer. What is the treatment protocol?
Both options are bladder preservation or the non-bladder preservation. We'll give inform the patient the relative what was the treatment of protocols. The bladder preservation we use the trimodal therapy like the TURBT followed by the CTRT.
Which TURBT?
Axial TURBT. Then CTRT. And if patients are going for the surgery, radical cystoscopy followed by the reconstruction.
How will you select patients for bladder preservation?
Contraindications. So, this is present at the mutation, then multicentric disease.
So then you will do preservation.
So, contraindication.
If there is moderate hypouricematosis, then
This is contraindication.
So there is no role of neoadjuvant chemotherapy and muscle invasive bladder cancer. You said you are doing surgery still. You only said just for TRBT, and you have to by and then you said that it's still. So is there any indication of giving neoadjuvant chemotherapy in these cases or it's not there? No evidence is there for NCT in bladder cancer, muscle invasive TCC? 1%. He is saying there is no neoadjuvant. So there is no role for neoadjuvant chemotherapy. As
standard. Yes. What drugs you give for NCD? What drugs you give? And
Another regimen also.
along with these two, what you have nowadays? What map you are using? No. Start with B. Why you want to do what has it done to along with cancer and systematic? It's only the game of VFS. There's 33% complete response when you get this. 1500 milligrams, day 1, 1000 milligrams, day 1, 7, that is the cancer, 200 milligrams, 200 square liters, 4 cycles, VSS, surgery, and 12 cycles. This is the protocol, as Ananda said about the person VSS in these cases. Wonderful. You cannot operate straight away to this. It's very important. Along with staging cystoscopy checks, what we do is looking at is a biopsy from the urethra also, check for the length of the urethra. Yes, sir. Go to the next. Forward. Not even on the next. Anything so that I pinpoint somebody on the date of this instrumental problem. That's it. Come in.
Okay.
No, what is that? Identify what? Engagement थोड़ी कुछ है आपसे. Marker replacement check. What is not the term for this instrument? Indications. When there is a lump, I want to localize it. Only lump is the indication for localization. Only these are the two indications for any other microconcentrication? What are these? Yes. What size are these? What size are these? 3 mm. Down 3 mm. Tissue mark. Next. Sometimes the answer
that will include the skin for canal, which is then canal, rectum, and heart.
Second question, find TNE.
So in TNE, very for adequate TNE, there is only node is going to be there. So
Where is calling? See, this is a question, simple question. What is TNE? So when you start writing also, explaining also, first thing you have to say is TNE stands for done for this, meaning this includes this advantages, looks like babies.
What is TMR? You said TME, there's one term also TMR. Total mesometrial discussion. Total mesometrial discussion. For what we do it? Cervix.
What is the mesorectum contain? Why do we have to dissect it
to deplete the local regional nutrient.
What is the regional rectum? What does it contain? Mesorectum. What does it contain? When you do an MRI, what do you see there? Sorry? I say lymph nodes, they're prompting you. You can have mesorectal lymph nodes. What else? The local tumor extension itself. Okay, so you get some circumcision marker by getting the entire mesorectum out. So it's the purpose. And eventually this will lead to reduced local regional recurrence. But can you avoid radiation because of that? Is there any indication that if you remove the complete mesorectum, then we can avoid radiotherapy?
Yes, what you are saying is right. Radiation is given anyway before.
DP onwards is particularly given in rectum theoretically. If it is early tumor, then if complete mesorectal dissection is done, then it can be avoided even and T2 also.
चलो चलो जल्दी नींद आ रही है देखा नहीं कभी चलो नेक्स्ट नहीं नहीं अच्छा what is this who said that नहीं this is our problem we have stopped seeing stomas because the company people are available. We just delegate this thing to them, and we are not teaching the patients stoma care. Our residents are not seeing any stoma irrigations and everything. This is our problem. This has to be. This is a stoma irrigation set. Advantages are once are there if the patient does irrigation. This is a cone which is put on the stoma, and that bag is filled with water and warm water. They might put some salt also, otherwise just warm water. Let it go into the stoma, then that sleeve is there, right? This sleeve will take out the effluent out, it goes into the toilet. Do it 1 or 2 times, filling the bag. It takes about 15-20 minutes. After that, the whole day, the patient might not have any motion, right? Later on. So, every patient with a permanent stoma should be taught irrigation. Remember, you have to advise them. Company people are very smart. They don't give these bags also. Why? Because if they give these bags, the sale of their disposable bags is going to go down. So we have to teach every patient who has a permanent stoma to do irrigation.
So, who answered this?
Deepak.
So, Deepak, like, if you are doing BPR and you want to make a stoma, you will make a stoma, right? Yes, sir. So, how do you mark the stoma sequentially and then how do you make a stoma?
Mark it in the sitting position.
After surgery, before patient surgery, then not before. How do you do?
Before surgery, before reduction.
How?
In sitting position, on how it skin bridges, it should be away from body problems like hydrocephalus, relaxed spine. We have to mark it on the most prominent area, not on the face. It should not fall down to the face.
And how do you want to make a colostomy? It's a flush colostomy, it's a new colostomy, it's a protruding colostomy, whatever colostomy you want.
For colostomy, sir, we can go with flush colostomy. Flush colostomy.
This is one related to as detail you everything about it. And having these other parts in the bag and stomach bone and the Yes, Dr. Gamma. Awesome. When you have to speak on your how would you answer? They will give you marks, they will not give you marks.
Suppose if you use a peritoneal colostomy, then why this gallbladder is a part of system? Gallbladder is not a part. That's why you want to get margin or for the margin sake, I will do resistance.
What we say is
You can leave the gallbladder because you won't compromise your kidney margin in case of peritoneal or but the ratio of taking the gallbladder the function will be lost.
The main function of gallbladder is total bile. We are using the bile duct.
This is the question. This is the whole display. We can cut even below the sphincter junction.
Sphincter will be cut, sir. You will have sphincter will be cut.
sphincter is the
नीचे से लगा
gallbladder में अलग
continuous तो सर स्पेस होगा ही नहीं उसमें. That bile is going to be
is best to comment on this? The proximal end of the GG node, distal end of the CBD, penetrating the
अभी बात है
vascular margin, okay, vascular margin, not the remote penetrating margin.
not finished. Not finished, I'm sorry.
In this case, when do you call it as like total when reconstructible versus non-reconstructible? Total when is invaded, then you can reset. Reset the tumor. Or total when is more than 180 degree or something.
Total thing convergence is there. Basement is there.
Scotland carcinoma, you can reset and put a graft. Reconstructible means either you can primarily repair it or you can put a graft. Both are reconstructible. So he is asking where you cannot reconstruct. That will become unreset.
But encasement is more than 180 degrees.
You reset it.
Then you will reset and reconstruct. But there is indication of this section.
Either it is too distal or too proximal. Okay? Either even it has a non-digital way, means it's in most distal part of the SMV, where your first digital vein enters. That is involved, you cannot go into instantly to reconstruct that vein, or it is going to be there up to the right. Things you can reconstruct, you can reset on the splenic vein, to splenic vein, and you can graft it. Or even you can reimplant the splenic.
In the preoperative imaging, radiologist has commented that there is right replaced or right accessory defective artery. So then where do you encounter that lesson? While doing dissection.
Where, which posterior, which area? Posterior to the portal. Where it is coming from? SM. What is the mouth of this hole then?
So while doing dissection in the incident.
What is Sandeep? Sandeep, no? I'm for your name. Not to come here. So, patient has come with you in the next wedding. Please discuss with the patient how to do neck examination. You have to do neck examination. Discuss. Please come with next wedding. Do neck examination. Thank you, you cannot listen. Wow, do this. Proxy is. Help कर तो सीखना पड़ेगा ना आप कौन भी बता दे you tell me speak on okay
मेरा नाम डॉक्टर नकुल है आपके गले की गार्डेंस की जांच करूँगा फोटो में आपको जैसे इंस्ट्रक्शन दूँ वो भी आपको रसना है
wait now this is right in the just what you did just now
He did not tell the whole steps of doing neck examination. He started touching the neck. What did you miss? So you have to speak to the patient. Go and speak to the patient. क्या आप कैसे जांच करोगे? You will be front or back or whatever.
आपके गले की नाड़ी या सामने पीछे खड़े होना इसके लिए आपको अपनी जगह थोड़ी आगे झुकानी पड़ेगी जो इंस्ट्रक्शन दो
So what about consent? So are you okay with that?
या मेरी जो पहला आपको है उससे आप सहमत हैं
What else he should speak during after this? What he said. Say, अगर दर्द हो कोई तकलीफ हो तो आप मुझे बता दें. So I'll stop it.
कोई जांच के दौरान कोई भी दिक्कत महसूस होता है तो
Stop. One of the examiners was very harsh. When any student started palpating, you would ask, are you married? Yes or no? Well, then you would say, "Achha, you want, supposing you are not married and you go and meet a girl, what will you do first? Will you start palpating first or do an inspection first?" Understand that? Everybody remember that? Everybody will remember that. For inspection first. Right?
Everything on you, whatever you are expecting. Authorities are sitting there. I'm not.
I would like to first internet and the angle of the patient.
So take whatever you want to do.
Properly expose the
No, you have to do it. I don't know. Just show how you do it.
properly expose the patient and at the level of the patient. I will first inspect the neck to see for the location of the swelling, to see the overlaying skin, to see presence of any other swelling or any other lymph node. Then I will start our patient.
Anybody want to add something here? Anybody I patients want to add something here? Or they are not? So you speak all the things of inspection findings. बोलो. Practice.
Look for
हाँ बोलो. You don't have to answer. आप उसको देखते बोलते रहो. Dilated veins नहीं है, swelling नहीं है, और क्या? Skin ठीक है. What else?
what else of the
No?
Keep explaining.
What you did is to speak.
from the first I will speak with the and then I would like to clearly first I will see the septal region in the submandibular region in the upper jugular region.
Is this the right of palpating the neck?
One side
Yes. You are palpating with both hands. You are not able to appreciate findings on both sides together. So one side each. Better you can start from below. So why did you flex the neck at the head of the patient? Why did you flex you want to get relaxation or something else? Plasma, what is the role of plasma here? Deep cervical position. You want to relax it? Why? What is the incision of the cervical fascia? Go into the
Start.
Also, when the patient swallows, check whether even if it's not inhabited, still ask them to swallow. Oral examination.
Is that done? No? You want to do something more? What is not done? Inspection, palpation, vibration, auscultation, and neck movements. Movements. Right side, left side.
Showing the posterior aspect of the anterior aspect. What determines whether it is posterior? How do you know that this is anterior? Rotational vision.
What do you have? Sir asked, it is anterior, posterior. What do you say? It is anterior, posterior. What surface is shown as an anterior surface, posterior surface? What is something else? Yes. So say it is a cut section. Which cut section it is? So how many types of cut sections are there in the body? Axial? Right. What it is? Then you can oh yeah, this is too easy a question. There is a last command to ask what type of question is.
What is the relationship of the artery, ureter, and vein? Anterior to posterior. Because if you know that exactly, then only you can go in for the small surgery. And this is anterior. Chalo, I'm holding.
Vein, artery, and okay. The first structure which you see, the vein
layers of kidney layers? From I'm not seeing because there is one hands now. What are the layers covering the kidneys? And how to regulate the posterior or posterior? Surface renal capsule. Then you are happy with this description? I was here with something here also. बिना बात इसके कितने निकाल देंगे? There was no indication of it. So we want to say that. We want to say this surgery was unnecessary. Am I okay with that? Could you have done a partial nephrectomy? Can you identify the pathology and describe the pathology here? Point out. Point out. Yes. Indications for partial.
Small
What size is the indication? The size criteria. What is the size criteria for partial? Please tell me. Less than 2 centimeters is the indication of partial nephrectomy. What centimeters is the only indication of partial nephrectomy? Once again, one person. Okay. So now tell the criteria for all exotic endophatic tumors for partial nephrectomy. For size criteria. And what is exotic and endophatic in kidney control? And there is RCC control. So what is the size criteria for partial nephrectomy? Maximum. 7.
For minimally invasive for 7.
Size is a criteria.
Then 7 centimeters. Minimally invasive 7 and over.
You can say there are now scoring systems, different sort of scoring system, renal, and all. So size is not the only criteria. You take the other factors. That is quite detailed. Okay, so you can see that in renal score, RE and the 5 criteria, they have to be taken into account. If you take the size criteria alone, yes, it's possible to do partial effectively in 7 centimeters.
So as Dr. Kamal is right, it is 10 centimeters. The maximum size you can remove with partial depending on the necessity. Both are about 10 centimeters. So a partial. What else? Other indications of partial. Size. Yes. So the solitary kidney.
See, the liver regenerates. Okay, liver can regenerate again, but kidney can't. Whatever the nephrons are there, they are not going to again regenerate. So the whole idea is to preserve at least 30% of the renal mechanism. We don't want the kidney to regenerate. We just want that the hyperfiltration effort can be present. Okay, because if the parenchyma is less than that, the entire renal flow will flow through that, and after a few years, that kidney will be non-functional because of hyperfiltration will
Split renal. Thank you. Split renal. He is asking something. So he is asking something. So now we have a lecture now from Dr. Jeevan. Vishnu is here with us. He is the additional professor in Nehru Department Surgical Oncology, all at Indian Institute of Medical Sciences.
Good afternoon. It's always very nice visit to be in an institute where you started your medical education. So you don't know that I was a student of first batch of this institute in 2001. After that, I moved, so did other degrees, but and today we met Dr. Kasa. So he's a very nice, he's a gentleman, and he is the self-made person. So he made this institute, and this institute is the one of, I think, so first in many things. I think first in liver transplant and first in so kind of. So today my topic is the how to discuss instruments, specimen, and radiology during exams. So I think so we have already seen and you are presenting very well. So just I will highlight some points that whenever you have to be very clear about the instrument. So what is the instrument? So you have to be precise. More कुछ नहीं. So demonstrate. So you have to demonstrate your understanding about the instrument. So what is that? What are the different components of the instruments? How it is made of, and so what is the broad purpose of this instrument, and what is the specific name? For example, here there are different broad categories. So there is this is kind of abdominal wall retractor. You can say that. Then it comes into the category of the specific name, that is the Viva retractor. So then, that is the deep retractors. Then other category of retractors is the superficial retractor. Just like this is the Langenberg retractor or Jerdis retractor. So these are the superficial. So almost all these surgical instruments, they come into the different categories, whether it is cutting or dissecting, like scalp or scissors. So these are for cutting, clamping or occluding, so hemostatic forceps, that compresses blood vessels or organs. So accordingly they are made of. So that's why there are different components there. There are some instruments, they are just for grasping or holding the things. So just like so, to accommodate that organ, so then according to that structure there will be tough instrument or or so accordingly. And then another thing is the retracting and exposing. So just like retractors, superficial or deep retractor. Then access devices like nowadays because endoscopes and propars and so, and the energy instrument like so whether it is based upon the ultrasonic or in the bipolar or some. So what is the mechanism behind this one? So just you have to have a thorough idea about these instruments. So then next thing comes to this one, what is the structure and what is the design of this one. So structure, most of these surgical instruments, they are made of stainless steel. So here there is the golden coated. So that is the tungsten carbide. So that make this instrument for last longer. So these are the usually these are the like where you hold this one. So but in some needle holder or some, so they will be there in the front blades also. So that's why they make these instruments long lasting. Here you have to see the different component. So that is the ring handle. So that is sturdy and you have to hold and it should be comfortable according to your hand. Then this is the ratchet. So some instruments will have ratchet but some will not have. So that depends upon their function. Then there is the strength or shaft. The shaft length of the shaft also depends upon what is the use. So if you are doing like surgery in the superficial space, then you will want like small length. So length of the instrument will be depend upon this shaft. Then there will be the joint. So most of these instruments will have box type of joint there. So one shaft of the instrument that goes inside to the another one, or there might be some pivot joint. And then anteriorly there are the blades. So anteriorly, so these blades they will depend upon the whether they are longer enough or small size. Then you have to see the how is that tip. So tip is the blunt or sharp or is there any tooth over there. So there are different purposes of this one. So accordingly the instrument intended to grasp like it depends upon like traumatic or atraumatic. Like traumatic is that Alice versa, that is traumatic. So you will hold that tough structure. So that's why that is the purpose. Atraumatic you can hold bowel, you can hold vessels, and accordingly there will be prominent serrations or there will be subtle serrations. So you can identify those instruments with that serrations. And as I have already mentioned, these are the different components of this one. Then ratchet. So that is the interlocking mechanism. So ratchet will be mostly for the hemostatic or to hold these structures, or then strong ratchet will be there for the needle holders. Then third thing comes to that is the function. So how does this instrument works? So whether you are for clamping or holding, so these are the different kind of like grasping like instruments. So then it comes to the clinical thing. So what is the indication? Where do you use? So most of these parts are all related to the instrument. So they will end here. Then you will go for the indications or clinical thing. What are the services? So you should have one in your mind that these are the some procedure where you will do. For example, this is the Johnson retractor. So that is for upper abdominal surgery. Or if you are doing like total peritoneotomy and with the high pay, so then you will need this kind of retractors. Then is that what is the safety and handling of this? How these instruments are being sterilized. So most of these instruments are sterilized by the autoclaving method. Then you should know detail about the autoclaving. So what is the temperature, what is the pressure of this one, and what are the alternatives of sterilization also. So like if you look at there, so these are the different things. So you should have some idea of these things. Yeah, plasma sterilization. So there are various methods. So accordingly, so you will have. Then next thing is that for specimen also there is also same thing. Your answer should be that it should be structured and detailed and objective description of this one. So here also you have to identify what is the specimen. So how will you identify? There will be some key identification marks or some key features through that you will find. So nowadays, because during the COVID, we also started with the photography. Otherwise, because we were also getting this from our pathology department. So even many times even we would not identify. So they are, I think they are keeping this specimen for a long period. So for example, in this system, then you have to find out what is that. Here you can see that there is the nipple and there is some skin, so that's why then you can identify. So that is the key identification mark. So you have to find out. Then what is the size of that one, what are the dimensions, what is the contour, and what is the color. So whether color is the uniform or heterogeneous or because of hemorrhage, or so what is the appearance. Then on cut surface, like apart from this one, like cystic species, or so you have to find out and see. So where is the tumor and where is the homogeneous and what is the normal and what is the abnormal things in this one. So all those things you should have a like broad vision first to, and then you have to pinpoint. So what are the abnormal structures? Then you can see that is the like that is the growth, or otherwise this lumen of part of the lumen is seen of the colon. So in summary, for specimen also be systematic. Always describe the specimen in a logical order. So what is the name? What is the how do you identify that? What are the digits? What are the normal and what are the abnormal things? And what is the probable pathology of that specimen? So stay concise but thorough. Then last thing is that the radiology. So in radiology also that you have to have comprehensive overview of the imaging quality. You may have like single vision, so that's why just you are focusing one thing there. And so what is the purpose of that imaging? What is the technique and what is the interpretation? And then what is the clinical relevance? So first thing is the name of the imaging modality, and as you were here like mentioning. So whether it is X-ray, CT scan or MRI. So in the surgical oncology already, because you are in the super specialization, you have already done MS. So I think you will have basic idea. So of this imaging, then what kind of imaging, what are the, like whether it is with the contrast, if it is IV contrast or oral contrast, how will you identify whether there is oral contrast or not? So you will see in the bowel. So if there is some bowel, so oral contrast is also visible. So then different views of this one, like axial or coronal or sagittal, you have to have the idea that how it is important to have the different views of this one. And when you examine so which sections, so that also depends upon for different tumors for different sections. So as earlier was mentioned that CT scan typically for the infectious carcinoma, you will see first that in the artery that there will be enhancement, and then venous phase you will see that so lipid falls out. Then delayed phases you will see other things also. So you have to see, and then to evaluate the structure, you have to either you can come from the periphery to the center. So I think that will be the better to have first normal things. So from these are like if you are seeing the CT scan of abdomen, then you can see there is like distant mass, something liver is normal, there is no free fluids or some orbital deposits or capping is there, or some gross deposits are there. Then you can come to that organ, specific organ. So then you have to mention all those details, heterogeneous enhancing, and what are the size, like what is the length and size of the lesion, and what is then different planes with the other structure, because malignancy have tendency to infiltrate or to lose the planes with the other structures. So you have to find out these different planes, and then most important thing is the lymph node. So you should not forget about this. So what are, you should know that what are the distal lymph nodes and what is the drainage area. Then you will consider that these are non-lymph nodes. So then you can call it as a distal mass. So and to see any kind, most of in the CT scan, whenever you see, you have to identify the anatomy or organ. That organ that will be very well defined with the venous phase. So in the venous phase, different, but arterial and other phases, they will be helpful to find out some other or additional things. So most broad idea you will get into the venous phase, and then for like just like for HCC, you have to see the different sequential phases also. Like here you can see that in the arterial phase, tumor is enhancing, Then gradually when it is coming to the portal venous stage and delayed venous stage, last has gone. So you have to find, so with that you can diagnose. Just I have already mentioned that gland surrounding this tumor. So that is very important, and in surgical oncology you have to have that knowledge of the anatomy. If you have very good knowledge of the anatomy, if you are able to read this CT scan or MRI very well, then I think most of the things you can predict during your surgery. Then you can correlate these things. So I think then you can like imagine that if you are doing like major hepatic resection, then you can find out that I will do this one like for anterior portal lesion or posterior portal lesion, and there are some like smaller branches. So I am going to put my next step like around this one, then it might be around here node, then posteriorly if I am going for like right hepatic vein. So is there any other structures? So I think if you have all those, then there is the pyramidal approach for this one. So first is that you have to describe that what is the imaging modality, what are the different views, finding size, shape, margin, content. So using approximate like terminology. Then mention relevant negative things. Then next step is that finding. So morphological, what is your morphological diagnosis? Then you can come to the etiological diagnosis. So this is the way of telling the about this imaging. So thank you all.
Any questions?
If you don't understand any specimen, you can ask for another specimen. These are I would like.
Like you have given an image of the osteosarcoma, cerebral, you go to the upper margin, you can say that I will bigger picture, I will second picture. You can ask this, I want to see this further. Right? Discuss it out with the if you know about that is possible. We will have a photo session now and followed by photo each and then we work what we do and find out. Tomorrow morning we'll start again around 7:30. All should come here. Tomorrow we have 3 sessions, 2 lectures, 2 sessions and 2 lectures. So we'll start by 7:30 with breakfast, and then long cases for 2 teams, and short case for 1 team, and then we proceed for 2 lectures, lunch, conclusion, certificate distribution, all will be done. Post lunch we will discuss. Shall we do that?